Good afternoon and welcome to CSIS. I'm Steve Morrison. I'm the Senior Vice President here at CSIS and direct our global health policy work. So welcome to CSIS for this remarkable forum on malaria that we're holding here this afternoon. We're here today, as we'll hear in greater detail from Karen and from Chris and from others, we're here to honor Alan Magill, a legendary and inspiring leader, scientist, researcher, innovator who put us very much on the road towards elimination and eradication of malaria. And to do this, we chose to time this as we did on the week of World Malaria Day, and to do this in partnership with the American Society of Tropical Medicine and Hygiene, ASTMH. We're going to hear in just a moment from the Executive Director, Karen Gorleski, who came up with this concept of honoring Alan and was kind enough to ask us if we would be interested in partnering, which we were delighted to do that. And so special thanks to Karen and to her team for bringing this opportunity to us. And I would include in that Chris Plow, who you'll be hearing from in a moment, a former president of ASTMH with whom we partnered on a number of things, particularly with respect to Myanmar, and Gina Rabinovich, the incoming president of ASTMH. It's been a real pleasure working with all of them in organizing this program, which is an ambitious and full program for the entire afternoon. I also want, from the side of CSIS, to offer special thanks to a number of the staff here who worked to put this all together. Audrey Jackson, Dean Garba, Joe Jordan, Travis Hopkins, Marcos and Oliver, thank you so much for helping us with the production today. Catherine Bliss, a colleague who will be speaking on our first panel, thank you for being with us today, Catherine. So I'm going to turn the podium over to Karen to say a few words to kick things off, and then we'll be on the road. Thanks, Karen.
Thank you. Thank you, Steve, and thank you for everyone for joining us here today. Today is the first, as Steve said, of this annual symposium that ASTMH will hold that brings together science, policy, and partnerships on the status and challenges as we accelerate to zero. When Alan Magill passed away so suddenly and shockingly, leaving us around the world feeling a bit adrift, Bruno Moonen from the Gates Foundation came to Chris Plow and me. Chris was president of ASTMH that year, and he followed Alan as president the year before. And Bruno said, we want to be a part of your plans to honor Alan and build on his legacy. Whatever you want to do, we want to be a part of it. Today is one piece of that legacy. Working closely with Bruno and the foundation, a generous donation from the foundation as well as a personal donation from Bill and Melinda. We are doing three things. The first is the establishment of the Magill Fellowship, and this will be the first person selected as the first Magill Fellow will be announced at this November's meeting of the Tropical Medicine Society. Second is at the TropMed meeting, there will be an annual eradication symposium strictly on the science. We held the first one last November. And third, timed with World Malaria Day, is this symposium, bringing science to Washington. And I'm particularly happy to say science came to Washington big time on Saturday as well. So the Gates Foundation has made this possible, and together we are committed to this for the next 20 years. So each of you can expect an Outlook invite on your calendar for the next 20 years. Before we get to the reason why we're all here and get to the interesting conversation, I too want to thank the speakers and our partner CSIS who built this event with us. Like so many things in science, we need our partners, and this is just one more example. Thank you, Steve, Audrey Jackson, Dean Garba in particular, who managed a lot of the invitations and tracking things and keeping us all on track. So with that, we're going to move to an introduction of the 2 videos. So we reached out to Senator Coons, who's the co-chair of the Malaria and NTD Caucus, and also reached out to Mark Dybel, Ambassador Dybel. Each were unable to be here, but felt so strongly that they wanted to make sure that they at least could be here in a way through a video message. So first we'll hear from Senator Coons and then Ambassador Dybel.
Hi, I'm U.S. Senator Chris Coons from Delaware. I'm sorry I couldn't be with you in person today for the inaugural Alan J. Magill Malaria Eradication Symposium, but I'm grateful for the opportunity to be with you all virtually and to share a few thoughts. First, I want to acknowledge the incredible legacy and vision that Alan Magill leaves behind. Through his work with the Army, the Walter Reed Army Institute of Research, and the Bill and Melinda Gates Foundation, Alan created a new vision that through collaboration and dedicated research, the world could eradicate malaria. What once was unthinkable is now a common goal we are working together to solve. His legacy will live on through the great work that many of you are championing each and every day. I also want to recognize the American Society of Tropical Medicine and Hygiene, the Bill and Melinda Gates Foundation, and the Center for Strategic and International Studies for convening this great symposium, and for all the incredible work you are doing to further our shared goal of eradicating malaria. On the eve of World Malaria Day, it's important to step back and think about how much progress we've actually already made. For all of the progress we've made, we are at a critical moment. We must continue key U.S. investments in critical federal programs like the President's Malaria Initiative and the Global Fund. These programs have shown remarkable results. And under Admiral Tim Ziemer's great leadership at PMI, the world saw a decade of unprecedented progress in the fight against malaria, leading to a 29% reduction in malaria mortality rates globally since 2010. Fortunately, programs like PMI and the Global Fund have strong bipartisan support. As an appropriator in the U.S. Senate and co-chair of the Malaria and Neglected Tropical Disease Caucus, along with Senator Wicker, I plan to continue the fight in getting the critical federal funds we need to make Alan Magill's bold goal of a world without malaria a reality. I hope you have a great symposium. Thank you.
Good afternoon. I'm sorry I can't be with you at CSIS. Steve, thanks very much for inviting me. But unfortunately, I had to get back to Geneva. But I wanted to be with you at least virtually for this important event to talk about malaria elimination, but more importantly, to celebrate Alan Magill's life and contribution. As you all know, we are on the path to malaria elimination. In the last 15 years, it's been an extraordinary moment in history. We can actually see the end to a disease that has been around literally since recorded medical history for thousands of years. But it's a tough path, and we need to stay on it. As you know, with the last 15 years, we've had a remarkable reduction in new infections and deaths. Some countries, more than 50 countries, 75% reductions. We have 21 countries on the path to achieving elimination by 2020. But as you all know, the final steps of elimination are the most difficult. The final steps of anything, any disease response is the most difficult. And equally important is staying in elimination when a country gets there to ultimately get to eradication. So it's going to be a very exciting time, but a very challenging time to keep our focus, to keep the resources, and to ensure we achieve that remarkable goal, the goal of the Sustainable Development Goals. Now, the Global Fund's playing a key role in that, and it's an honor to be with you from our offices here in Geneva. As you know, the Global Fund is the largest external funder of malaria. It's a financier, but we're partnered with financial and technical partners, importantly the US President's Malaria Initiative. I really want to acknowledge Tim Ziemer too, who's back in service at the White House, and the key role he's played to link the PMI program with the Global Fund. But clearly the leadership of WHO, which has to certify and help maintain countries, surveil and get to elimination and maintain it and get to eradication. DFID, UNICEF, and other key partners all working together to support primarily and only the countries, because it will be the countries that have to get to elimination, and importantly maintain the systems to move from elimination to eradication. A key partner in all of this, especially the drive for elimination and eradication, has been the Bill and Melinda Gates Foundation, including Bill's strong leadership. But we all know that it was Alan Magill who came from the Department of Defense to the Gates Foundation that drove that agenda internally, that put together the science, that put together the implementation, that had the vision to say we can actually not only eliminate but eradicate malaria. And that's a reflection of Alan's remarkable life. As a researcher and scientist, as a teacher, as an implementer, as a policy innovator, and as a creative person who could bring people together. Also as the president of the American Society of Tropical Medicine and Hygiene. But it was really Alan, when he came in, that pushed that agenda within the Gates Foundation and therefore pushed the agenda globally. We wouldn't be on this path without Alan Magill. We wouldn't be on the pathway not only from his brain, but from his remarkable heart and great sense of humor and collegiality in bringing us all together. And there'd be no more fitting tribute to a remarkable scientist, teacher, implementer, but also a remarkable person than to achieve elimination and ultimately eradication. So let's go do it. Thank you.
So our first panel discusses the role of U.S. leadership of malaria eradication, and we've asked Chris Plow, a close friend of Alan's, the director of the Institute for Global Health at the University of Maryland, where he leads a very ambitious effort at developing new drugs and vaccines, and is putting a special focus on resistance and carrying forward research in Africa and in Southeast Asia, elsewhere. We've asked Chris if he might kick off the afternoon symposium and this opening panel with 15 or 20 minutes of a tour d'horizon. And then once that's completed, we'll transition into a roundtable discussion with Chris, and I'll introduce our other three speakers at that time. So please join me in welcoming Chris Plow.
Well, thanks very much, Steve and your colleagues at CSIS, Karen Gorleski and your colleagues at ASTMH, and Gina, who put a lot of effort into putting this together. And am I able to advance my slides? Yes. So we're here today to talk about malaria. And I used to have a slide that said in the next hour, 300 children will die from malaria. On the right there is a child who died from cerebral malaria in the morgue at Queen Elizabeth Central Hospital in Blantyre, Malawi. And in the center is one who responded actually to chloroquine, the old drug that now works again there. As you know, malaria is not just a problem in the tropics and for people living in developing countries. For example, it's been a major cause of casualties in just about every military conflict since the Civil War. And this shows a soldier suffering from malaria in the Pacific Theater in World War II. And by the way, malaria is a problem in North Korea, just in case anybody was wondering. And so we're here to honor Alan, who had a long and storied career in tropical medicine, military medicine, and especially malaria, first in the military, and then the last few years of his career at the Bill and Melinda Gates Foundation. And Alan adopted a coin that was originated with the malaria vaccine program at Walter Reed. And on that coin, it says malaria delenda est, or malaria must be destroyed. Now, does anybody here happen to have a malaria delenda est tattoo? I know that some people, nobody wants to volunteer. I'm still thinking about which font to get mine in. But that was Alan's motto: malaria must be destroyed. And the first scientific symposium, part of this program, was held last fall in Atlanta at the ASTMH meeting. As you can see from the photograph, it was jam-packed. This was the biggest room at the meeting, and there was literally standing room only. There were people who couldn't get in, and that was a terrific scientific symposium. And so this is the first of the policy symposia as part of this program. And so the reason we're now talking about eradication, the reason that Alan dedicated the last several years of his life to working toward malaria eradication, is because Bill and Melinda Gates made a case in 2007 that eradicating malaria is a matter of social justice. The argument was that if it's not okay for our kids here in the US to be dying of malaria, it's not okay for kids to be dying of malaria elsewhere in the world when we have the tools at our disposal to at least eliminate it and down the road to eradicate it. So just a quick word about definitions, right? Malaria control means, or just in general, controlling a disease means reducing the incidence of the disease to the point that it's no longer a major public health priority. Elimination refers to interrupting transmission of the pathogen and a fall in disease incidence to 0 in a given area. So we talk about a country has eliminated malaria or eliminating malaria at a subnational level in a region or a state or a district. Eradication, the goal here, and these words get mixed back and forth quite frequently, but what we're talking about here, the reason that Alan dedicated the years of his life to this, and what we're all about is eradicating malaria, interrupting transmission worldwide, and a fall in disease incidence to 0. And then, of course, extinction is when you no longer even have any of the bugs in the freezer. So just by way of background, malaria did used to be a significant problem in this country. The darker, this is a map of the proportion of all deaths that were attributable to malaria in the 1870 census in the US. And it was also an issue out west as well, but just kind of showing you that there were malaria deaths all the way up into Michigan and into New England. But we know that malaria can be eliminated because we've done it here among many other places. This is the map of the distribution of malaria in the US in the late 1880s. And by 1912, and then in the 1930s, and then we eventually got rid of it in the middle of the 20th century, largely through prompt diagnosis and treatment, and improving standards of living, people living indoors. But even today, we still have the vectors. We didn't get rid of the mosquitoes. We got the parasites out of the people, and we prevented mosquitoes from transmitting, but we didn't eradicate the mosquitoes. So this is a map of the distribution of mosquitoes that can transmit malaria in the United States today. And even now, we still have little outbreaks of locally transmitted malaria. So this is something to remember when you're talking to policymakers, appropriators in this town. This is still an ongoing issue in the US locally, as well as for travelers and military and so forth. But based on the availability of very good drugs, quinine, but then especially chloroquine, and on the availability of effective insecticides, the world decided to attempt to eradicate malaria in the late 1950s, and that campaign went on then through the 1960s. And during the 100 years before that eradication campaign, the first eradication campaign, if you look at the map of where malaria is in the world, you can see that it was very widely distributed. At the beginning and the end of that 100 years, there's very little difference in those two maps. So this is 1945, and up there is the mid-19th century. And then if you look at what happened to the malaria eradication map between 1945 and 1977, spanning the eradication campaign, you can see that the malaria map shrunk very dramatically. There are large parts of the world, North Africa, the former Soviet Union, parts of Asia, where malaria was a significant problem. There's no longer malaria in those areas. So that was really the result of the eradication campaign. It didn't eradicate malaria, but it certainly did eliminate it from many parts of the world. But then, as you well know, there were many issues that contributed to pulling back from eradication as the primary goal. Chief among them, though, were the emergence of insecticide-resistant mosquitoes and drug-resistant parasites. And then what happened when we stopped trying to eradicate? Not too much. The map doesn't change much at all between 1977 and 2007. And at the time when I got into malaria research in the late 1980s and early 1990s, this is what the trend lines look like. The top line there is the total world deaths from malaria, and it peaked at around 2 million, even higher than that by some estimates in the early 2000s. And then something happened. And if you want to know what happened, this slide pretty much tells it all. This is the external funding made available for malaria control and then later on elimination efforts to endemic countries. And the funders there, the primary ones are the US President's Malaria Initiative, the Global Fund, of which the United States is the largest single contributor, and the World Bank, of which the United States is the largest single contributor to the health efforts. So really, the lion's share of these resources came from the US government. And that trend had a real impact. And the way that it had that impact was basically through prevention, largely through insecticide-treated nets, through diagnosis, largely through distribution of rapid diagnostic tests, and treatment, largely through the distribution of artemisinin-based combination therapies. And the result was that the map shrunk further. So as of now, 62 countries have eliminated malaria. There are 96 countries still with malaria. 35 countries are actively committed to eliminating malaria, and 9 are considered right now to be close to elimination. I think actually this list is a little bit obsolete because Sri Lanka has now recently been certified as having eliminated malaria. And it's not just on the periphery of the map that progress is being made. I mean, there are other countries in sub-Saharan Africa for certain that are not such success stories. But there are several good examples where the governments are committed, where the donors have come in and worked in partnership with the local officials and health systems and had results like these, where you get very dramatic reductions in malaria in places like Zambia, Rwanda, where you might not have thought that that would be so quick to happen. But now what's happened with the funding in the last few years is this is kind of picks up about halfway through that earlier graph, and you can see these are the same funders. You can see that the funding levels are beginning to plateau, if not even diminish a little bit in the last couple of years. And so coincident with that plateauing and even diminution of resources has been the emergence of resistance to the artemisinins. This has been a real concern that CSIS, among others, has really tried to look into this and have some discussions about the implications of this here in Washington. This was a report on the right that we did on this topic. So I wanted to make a quick point about the need for R&D, which will be the subject of one of the next panels. So in addition to having resources for nets, for rapid diagnostic tests, for drugs, we do need, for example, I think we need a vaccine, and I think we'll hear about vaccines in one of the upcoming panels. But another example of how research contributes to elimination comes from studying the emergence and spread of artemisinin-resistant malaria. So if you look at the map on the left, the darker colors show the prevalence of the artemisinin-resistant parasites based on a genetic marker for resistance. And it looks for all the world like a wave of resistance moving westward from Cambodia. And that was widely assumed to be what was happening. And the strategy initially was for containment. The idea was we can put up a firewall and prevent the westward spread by eliminating malaria along a corridor along the Thailand-Myanmar border and keep it from spreading into Myanmar, then India and Bangladesh and beyond. But when we did essentially paternity testing, we did genetic testing of parasites, not just looking at the resistance marker, but at markers upstream and downstream from that. We basically found that there was transnational spread of the resistant parasites, for example, between Cambodia and Vietnam, but that all the parasites that were resistant to artemisinins in Myanmar and in China were of local origin. So it was both popping up independently and it was spreading. And that's what this map shows, many different spreading events, and the polygons are areas where there's a whole area where a resistant form has spread, but lots of also punctate poppings up. And so based on this kind of research data, the WHO then recommended that we need to abandon the containment strategy and move toward complete elimination of falciparum malaria from the greater Mekong subregion. So I want to also build the case for the importance of capacity strengthening. This is a long game that we're playing here, and it can't be up to the donors and the universities from the Western countries to do this. We really have to invest in the countries. And so I think one of our speakers will talk a little bit about work along these lines in Myanmar in Southeast Asia, where we're helping to bring all the different partners together to build capacity, especially for surveillance. That becomes very important as you move toward elimination. In addition, I think Myang Nyut, one of our speakers, will talk about an event that was held here where we brought together not just the civilian health officials, but military health officials, ethnic militias, other key partners from Myanmar to get them to cooperate on malaria elimination in Myanmar, irrespective of free and fair elections and the need for signing ceasefires and so forth. So to make the point that it's not just about the public health interventions and about the R&D, but the partnerships are also very critical, and one of the later panels will focus on that. So I'm going to end with a series of slides to make a single point, which is that if we let up on the pressure, if we pull back on the resources, we're looking at a horrific picture of resurging malaria. There was a very nice full-length article in The Atlantic several years ago, back in, I want to say 1997, that described what had been happening in the 80s and 90s with that trend line you saw earlier, with this terrible resurgence of malaria and vast numbers of deaths. And there's a very nice, detailed look at this in the Malaria Journal from just a couple years ago. And basically, no matter which way you slice it, you can see again and again examples in many, many different countries of what happens when you pull back on malaria control and elimination resources and efforts and programs. So here are a whole series of trends of what was happening with malaria rates in Latin America when they weakened the indoor residual spraying programs in all these different countries. It resurged in Asia and Eastern Europe, both when there was intentional and when there was accidental weakening of the malaria control programs. Malaria resurged following wars, population movements, civil conflict, other social disruptions in Europe and in Asia, some very dramatic increases. And it has resurged in Africa in smaller areas when pilot programs were stopped and when control activities were released. So the messages I would like to leave you with is that eradication is a long road. When Bill Gates was our keynote speaker at ASTMH a few years ago when Alan McGill was president, the ASTMH Council got to ask him some questions, and I got to lead off with the first question. And my question was, given how hard eradication is going to be, and the many historical examples of donor fatigue and people kind of getting tired of one problem, wanting to move on to the next one, how are we going to mitigate the risk of just sort of losing momentum for malaria eradication and having terrible resurgences? And he gave a very thoughtful answer, the gist of which was that we knew that going into this. And the foundation and all of the key partners who are in this effort understand that this is a decades-long effort, and it's incumbent on us who are working toward malaria eradication to make that point again and again and again to people in decision-making positions with perhaps shorter-term memories. So I want to charge you all with the mission of going out and doing that. But I think there's very clear evidence that as we move toward eradication, many, many lives are being saved and will continue to be saved as we go down that road. Reaching the end is going to require this sustained commitment as well as new tools, things like vaccines, like more sensitive diagnostics to identify the infectious reservoir. And finally, the most important point I'd like to leave you with is that the risk of losing the entire investment that's been made in malaria elimination and eradication up until now is real and chillingly real. So with that, I'll turn it back over to Steve. And should I have a seat up here, Steve?
Sure.
Okay.
Bernard, I want to welcome our speakers. Marcos Espinal. Hi, Carlos. How are you? Marcos Espinal is coming to us from having just broken away up in, I think it's Bethesda. So he'll be joining us momentarily. But we're going to go ahead and just get started. So we can just remove this. Thank you. So thank you, Chris, for that opening. We have an overarching concern or theme around this panel, which is around the centrality of U.S. leadership, the kind of achievements that have been that we've seen in this last amazing decade, and the outstanding challenges that remain. We are asking our speakers to put a certain geographic focus on areas that they know the best, and so it was great that Chris could also spend a few minutes talking about Southeast Asia and the really serious threat posed by Artemisinin-resistant malaria there. We are going to now ask several of our other speakers to sort of carry the story forward. And I'm going to ask Bernard Nolan to be the first speaker. He has been, to many of you here, a very familiar personality. He's been the deputy director of the President's Malaria Initiative since 2007. And his career prior to that point had him occupying terribly important positions with WHO, with KEMRI in Kenya, as an advisor at the Global Fund. We've all come to really rely on Bernard over these many years, which is now approaching a full decade. I just want to add that when Tim Ziemer finished his tenure as the director of PMI, we hosted an evening here together with Tim. Bernard, you were with us, I believe, on that evening. And it was the day that he had handed in his badge. It was January 19th. And he had handed in his badge after 10.5 years. And it was a pretty emotional moment and pretty emotional evening. And there were about 40 people gathered. He did a podcast prior to that, reflecting on his own personal life and the achievements of standing this program up together with Bernard, which I'd urge you to listen to. It's Take as Directed, our podcast series. But what came across in that evening, and I think what's going to come across in Bernard's comments, is the remarkable continuity and sustainability of U.S. leadership over the period going back to 2005. We've had the same dedicated personalities leading this effort with strong bipartisan support from Congress over time. And in most major developments, major health or other related development programs, you don't have quite the same concentration of factors coming together, along with very clear goalposts and an ability to operate in close partnership with governments and with the Global Fund and with others. So Bernard's going to kick things off, followed by Catherine Bliss, who's a close colleague of ours here at CSIS. She's a senior associate, served previously as a deputy director. She's a Latin Americanist. She leads our work on immunization, on maternal neonatal child health. She's done a lot of work on the global health priorities and practices of the BRICS countries, and has just recently completed a terrific analysis of the health consequences of the implosion in Venezuela, which of course in our hemisphere here remains a daily and rising concern and has a terribly important malaria and broader health component to it. So thank you, Catherine. Thank you, Bernard, for being with us. I'll introduce Marcos when he's arrived. Over to you, Bernard.
Thanks, Steve, and thanks to the Center for Strategic and International Studies, and also Karen, the American Society of Tropical Medicine and Hygiene. It's a real honor to be here at the first Alan J. Magill Malaria Eradication Symposium. I hope I'm here for the 20th one as well, Karen, so keep sending the messages. And thanks to all of you. I mean, we talk about consistency and leadership. You're talking about the U.S. government, looking around the room and knowing many of the faces here. There's so many people who've been consistent in their commitment to the fight against malaria, both in where they still sit, but also knowing many of these people, you've moved to different places, but we don't do it. What we do in PMI is obviously not just what PMI does, it's what PMI does with all of you. So my comments, even though I'll focus on the U.S. government commitment, it really is about the U.S. government as an effective partner with the countries and all of you. You know, when PMI was launched in 2005, and I'll just go in a little history for maybe the one person in the room who may not be familiar with PMI at this point in time, it was a pretty, well, all I can say is, having spent my career at CDC working on malaria, and I heard there was this presidential malaria initiative, I frankly was flabbergasted and blown away and wasn't sure if I'd actually heard correctly, because who would have thought at the highest levels of US government there would be a commitment to malaria, and a significant commitment. And it was a pretty strategic reorientation of the whole US government approach to malaria. Frankly, the resources at that point in time, other than the resources on research, which were producing some pretty good results, the resources that were going to actually support countries to do something about malaria, I guess a polite way to put it is they weren't seen as being used very effectively. So not only did President Bush and his administration launch the President's Malaria Initiative, it actually created a totally different approach with congressionally mandated authorities over the budgets. It designated a clear leadership structure with USAID as the lead agency and CDC as the main implementing partner. But it also was an effort to try to corral all the US government resources and talents in malaria against a common good. So it also, NIH, NIH Fogarty, our FDA, our Peace Corps, and we actually have an interagency advisory group which includes all of the major US government agencies who have a role in malaria. The congressional legislation also required investments in essential malaria commodities and technical assistance. And really importantly, the approach was to actually support the National Malaria Control Plan and not come in with your own ideas or different things you think might be a clever way or a good way to do things, but to actually rally around a single National Malaria Control Program and national authorities. Presently, we operate in 19 high-burden countries in Africa and also in the greater Mekong sub-region because of the problem that Chris has already pointed out to, the emergence of Artemisinin resistance. The funding obviously is based on scaling up the recommended interventions on vector control with insecticide-treated nets, indoor residual spraying where it has a role, and previously in Africa there was other than a few countries, there was very little capacity for doing indoor residual spraying, and certainly when this all started, almost no country actually had a good level of coverage of insecticide-treated nets. Rolling out the better drugs, the Artemisinin-based combination therapies, and with the great new tool of the rapid diagnostic test, being able to move beyond just the bricks and mortars of health facilities, but actually get out to communities where malaria, and the poorest of the poor, and some of these communities which are beyond the extent of the formal health system frequently. The fact that you can actually go now and train someone in the community to stick a finger, have the result in 10 or 15 minutes, and to be able to treat on the spot and follow up in the community is pretty crucial and an important step forward for malaria. And that's resulted, you've already heard of some of the major decreases in malaria cases and deaths over the past decade, and some of the most recalcitrant, highest transmission areas and some of the most difficult parts of the world. The fact that that's actually happening is a success that everybody in this room can celebrate, and I think, and I'll just say it couldn't have been done without US government leadership. Not only because, as Chris pointed out, funding is important, and not only the funding through the President's Malaria Initiative, the direct bilateral funding, but the contribution of the US government to the Global Fund to Fight AIDS, TB, and Malaria. That's been important and crucial. And up to this point in time, both under President Bush and the expansion under President Obama, Congress, and seeing Senator Coons here is evidence of that, has appropriated every single dollar that the President's budget has asked for, and frequently will throw in a bit more. And again, that is further evidence of ongoing US government commitment, and I expect this will continue in the long run. And again, the reason they're willing to do that is because we have better and better ways of demonstrating what's going on with these resources. Are people being reached, and is it having an impact? The progress in Africa, and those of you who spend time in Africa, it's pretty remarkable in some of these areas, but obviously it hasn't been uniform throughout the continent. And we still have a ways to go. So when we talk about WHO estimates there's been about over 630 million cases that have been averted over the last decade, and about 2/3 of that has been due to scale up of vector control tools, primarily insecticide-treated nets. But still, there's about 43% of people in Africa that aren't covered. So we can go a lot further with the tools we presently have while we're prepared to hopefully more rapidly bring to fore the next generation of tools, vector control, vaccines, newer drugs and diagnostics as those become available. So I guess the point is that while the great research which is presently going on is continuing, we still have a long way to go with what we presently have available, and we're committed to doing that. Just quickly, the PMI strategy for 2015 to 2020, actually, in addition to further reducing morbidity and mortality by 40%, calls for working with at least 5 countries to meet the WHO criteria for subnational pre-elimination, even though WHO just abandoned the term pre-elimination, but I think we all know what that means, getting malaria down to such a low level that you can actually consider trying to interrupt transmission. So in addition to the 6 countries in the greater Mekong subregion, which have called for elimination in their national plans, in the Africa region, countries like Ethiopia, Senegal, Madagascar, Zanzibar, which is, of course, is part of the Republic of Tanzania, Zimbabwe, and Zambia have not only developed plans for pushing towards elimination, but have actually put some of their own resources into this. So those are the countries we'll be working with when we talk about pushing towards elimination. And it'll probably be at a subnational level in most of these areas. And yet it's perfectly doable in places like Senegal and Ethiopia and parts of Zambia and Zimbabwe. Lastly, just to repeat what Chris has said, we do need ongoing investments and new tools. We put some resources into the Medicines for Malaria venture, which you're probably familiar with on the drug side, to come up with new anti-malarial drugs, and also with the Innovative Vector Control Consortium, which is on the vector control side, again, trying to bring new vector control tools, at the moment primarily insecticide-based, to the fore. We're not the main funders of the basic science around malaria vaccines, but certainly USAID has been involved with many people in the room around the whole vaccine initiative discussion and looking at some of the exciting things going on in that space. So in the long run, our goal is the same as everyone in this room, which is a world free of malaria, and working with countries to continue to push the envelope to make sure that every community affected by malaria, every household, has access to the best vector control tools. And that every person ill with malaria has access to diagnosis and treatment, hopefully where the fever occurs, and in the cases of severe malaria, the ability to get to a higher level health facility where they can have the more aggressive therapy that would be needed there. So I expect, again, that the U.S. government commitment will continue. I have no indication that it won't. So, thanks.
We'll bank that one, Bernard. Thank you. Thank you very much. Marcos, welcome. Thank you for joining us.
Thank you.
Marcos Espinal, Director of the Department of Communicable Diseases and Health Analysis at the Pan American Health Organization, PAHO, based here in Washington, the regional office of the World Health Organization for the Americas. A long history of being a leading diplomat, a scientist, a public health strategist, a person that's put forward a vision for elimination and eventual eradication in this hemisphere, and a person who's played a lead role in multiple other issues. We've been very reliant on Marcos's help in a number of issues, on Zika, on the situation in Venezuela, on other pandemic flu-related issues. So thank you, Marcos. It's wonderful to have you here with us. And,
thank you.
So glad you could join us. Thank you.
Thank you, Steve. It's a pleasure. Let me thank Karen and Steve for inviting me to this event. Let me give you an advice. Don't ever you agree to give 2 talks at the same day, because I was just rushing from the other side of the city from the National Foundation for Infectious Diseases talking about Zika. So now I'm switching my topic. And let me start by thanking not only CSIS and the American Society of Tropical Medicine and Hygiene, but also the US government, before I go into my talk. When I moved to Plow from WHO 7 years ago, I went to visit Admiral Zimmer. He said to me, I promise you, you will have money from PMI until you eliminate malaria in the Americas. And they have fulfilled that. So I hope, what you said at the end, Bernard, he and I goes back to Geneva a long time ago. So it's fulfilled, and the US government continues its strong support, not only for Africa, which is the most needed, of course, but also from other regions where elimination can be achieved in the near future, and maybe before 2030. So thank you for the commitment of the US and the commitment of so many US partners to malaria. I mean, this country doesn't have a huge burden of malaria, or doesn't have malaria, basically. But, diseases don't respect borders. So on behalf of Plow and Dr. Etienne, many thanks. I just have 5 slides. I'm going to be very short, 6 minutes or so. And here is what I wanted to show you. You can see in the Americas, the country has done extremely well with the support of mainly of the governments, because they put most of the money needed. Most of the money comes from government budgets, but also the support of partners like PMI, but also the Global Fund, which the US, of course, is a major contributor. There are several countries that rely on the Global Fund. Haiti, one of them, Suriname, Guyana. In PAHO, we have 8 priority countries. Latin America and the Caribbean is a very tricky region because of 2 things. We have high-income countries in the south, Argentina and Uruguay, Chile also, and in the north, US, Canada. But we also have a lot of middle-income countries that are growing economically. But we still have low-income countries like Haiti, Honduras with a lot of problems, Guyana, Suriname, a lot of problems. So they will need Global Fund. So the first message is, let's not let the Global Fund to become a Global Fund for Africa only. It needs to continue being the Global Fund. And we know we need to be innovative. We know we need to submit ideas for joint proposals, because the burden of disease in the Americas is less. But it is important we keep that in mind for the next executive director of the Global Fund. So as you can see, what we have here is 2 graphs. The one in the left is basically showing the remarkable reduction of malaria since the year 2000, 62% reduction compared to only 450,000 cases. That's tricky also, because people say, oh, well, they are eliminating, let's forget about that. No, it's more difficult to eliminate than when, it's more detailed elimination. And there are countries that are still not in the phase of elimination. We have 18 countries that are ready to eliminate. Paraguay and Argentina are actually on certification for elimination. So very good prospect. Also with the strong support of WHO, a very good relationship with Pedro, and so on. Mortality, very minor. So there's no need for malaria cases to die. However, if you can see in the right side, that's the danger. In red, 2 countries, Venezuela and Haiti. In Venezuela, it was going down. I don't need to tell you what the problem is. You all know the problem. It's a political situation. Malaria is increasing massively in Venezuela, and we are afraid of 2 things: dissemination of 2 other countries in the region, and also creation of Artemisinin resistance. So very compelling evidence. Many countries going down, reducing malaria, about to eliminate malaria, or to start entering the phase of elimination. Others, like Venezuela and Haiti, major problem there. Where can we eliminate? Well, here is a slide. I don't know if you can see it from there, but starting in the top right hand, Hispaniola Island, a strong support from the Gates Foundation, from the Global Fund. For Dominican Republic has fewer cases than Haiti, but I think both programs are strongly committed to control and eliminate malaria. And of course, one of the roles of PAHO and partners is to make sure we nurture the binational work, the binational commissions, the work together of these two countries. And now it's a good opportunity because the two head of states are very committed. They met each other, and they're very committed to work together on the elimination of malaria. Then we have the Amazon countries, Suriname, Ecuador, Bolivia, where in these countries, you know, it can be done. We have a huge vivax incidence in Brazil, Mesoamerica, Central America, and the Caribbean. But mainly the countries, the 6 countries of Central America, they can eliminate. Strong support also from the Global Fund for a joint grant, strong support also from several other partners. And we think, you know, these are part of the 18 countries that in the Americas, we believe in the next few years, the job can be finished. And Argentina and Paraguay, I mentioned, 3 years, for the last 3 years, they don't show cases of malaria. And this is a summary, very low number of cases in some countries. In 2014, we have the lowest number of cases registered, but in 2015, increases in malaria in Colombia, DR, Ecuador. So the job is not finished. That's the point here. We need to continue pushing, PAHO, partners. An important thing that is critical for this, and I thank CSIS and ASTMH, is the advocacy. Political advocacy is vital here. Because when diseases are going down, people tend to forget them. And head of states, ministers, oh, well, not my priority. We need to keep pushing together. Because otherwise, it's not only PAHO. Everyone has a value added. And if we can bring into the table value added, that's critical. This is not really how. It's PAHO has, I'm not going to focus on this, but I can tell you PAHO has a newly approved regional strategic plan based on the global malaria plan. And the point I wanted to make is the last one. Productive partnerships will be critical to complete the job. So 30 minutes, no, I cannot have 30 minutes remaining. So 30 seconds, you mean. That's the last one. These are the line of actions, strategic actions of the PAHO strategic plan. It's available on the website of PAHO, but you can see universal access is vital, reinforce malaria surveillance, strengthen health systems, advocacy communication. That for me, when elimination is come to discussion, political advocacy is probably the most important one. Because after the head of state or the head of the government commit, the rest come by itself. Thank you. I've finished.
Thank you, Marcos. Catherine, thank you for joining us. I hope everyone's aware we've just published the study, Catherine's study on Venezuela. We have both hard copies available, but also available online. Thank you, Catherine.
Great, well, thank you very much. So in the early 1960s, Venezuela was recognized internationally for its malaria program and for having eliminated malaria in the most populous areas of the country, making it the first country in the region and perhaps the world to be recognized in this way. During the 1960s and in subsequent decades, Venezuela made significant progress in improving health conditions in the country. Some with US assistance. There was quite a bit of US cooperation on health and in other areas during this period. By the late 1970s, the country was a destination for Brazilians and Colombians seeking high quality care. But Venezuela's achievements in malaria control, reducing infant and maternal mortality, and extending life expectancy were not always spread equally across the country. And a period of low investment in social services, including health services in the 1980s, led to a popular uprising known as the Caracazo in 1989. And a cholera outbreak in the 1990s further kind of exacerbated and highlighted inequalities in access to health services and paved the way for a new approach to addressing social conditions through public programs. Now, with the rise of Hugo Chavez in 1998, the implementation of the Bolivarian Revolution, and the passage of a new constitution guaranteeing the population the right to health, Venezuela, which has the highest proven oil reserves in the world, increased its reliance on the use of oil revenues to support a variety of health programs. And perhaps the best known of these is a program called Misión Barrio Adentro, which brings health services to underserved communities in rural and urban areas. And these were to populations who were deemed to have been kind of neglected or forgotten during the previous 4 to 5 decades of a political process. But according to many observers, Barrio Adentro was really put in place alongside pre-existing public health programs, which were not necessarily dismantled or changed, and by many accounts created both a complex and sometimes contradictory set of initiatives and imperatives related to medical training and credentialing, as well as access to services and essential medicines, among others. So with the collapse of global oil prices in 2014, that's been associated with cuts for funding for social services kind of across the board in Venezuela. But the challenges facing the health sector are among the most severe. And these include instability in the health sector, with several different health ministers in recent years, health personnel not being paid, being dismissed from their positions, that investments in infrastructure have come to a halt, with reports of hospitals with no electricity, no running water, low supplies of incubators, broken or non-functional beds, and limited surgical tools or medicine delivery devices. A lack of information. The government has not reported maternal and infant mortality statistics since 2009, and has not published the weekly epidemiology report since 2014, making it challenging to forecast needs for medicines or procure the appropriate amounts. And finally, shortages of essential medicines. If you're on Twitter, you can see kind of on a daily basis, people posting, doctors and family members posting the medicines that they need for their family members and the amounts, and just asking if people can tell them where they might be able to get them. Similarly, an outbreak of diphtheria highlights challenges around immunization coverage in the country. And unpublished documents show that maternal and infant mortality is rising as well. The resurgence of malaria in a country once recognized for its malaria control program is grave cause for concern. As Marco said, in February, well, he didn't say this, but in February of 2017, PAHO reported Venezuela had an estimated 240,613 cases, so a 76% increase over the previous year. Most of these, nearly 50%, are concentrated in the southern state of Bolivar, which borders Guyana and Brazil. And this is a tropical region home to illegal gold mining activities, which are highly unregulated, very few public services, and very limited health services. Also very little use of insecticide-treated nets in this region. People have taken to crossing the border to the Brazilian state of Roraima to seek care or to purchase malaria drugs, which they then either take back to use themselves or sell at inflated prices on the black market, which has emerged in the area. So you have a situation in which untreated cases can exacerbate existing maternal and health challenges and others, and the potential for the increased emergence of drug-resistant strains of malaria in the region also. And this is not just happening in Bolivar state. At least 16 states in Venezuela are on malaria alert, and with the Venezuela-Colombian border also becoming a site for increased malaria transmission. So just to kind of go back to the 1960s, so between 1961 and 2016, Venezuela had gone from an international recognition for its malaria elimination program to international recognition for the resurgence of malaria in some regions of the country. Most of that has happened just in the last couple of years, as the economy and health system, both dependent on oil revenues, have collapsed. But with a growing black market for malaria drugs and increased migration of Venezuelans to destinations across Central and South America, as well as the Caribbean, the resurgence of malaria poses a threat not just to health in Venezuela and the border areas, but to the countries of the Caribbean and the Amazonian region that have worked to make so much progress toward malaria elimination as well.
Thank you. Thank you very much, Gavin. We have a little over 20 minutes. I want to come back to a question around U.S. interests, say a few words, and then come back to our panelists. Clearly, what we've seen over the last decade and longer is dramatic progress. We now have and the opening of opportunities for bringing a number of countries closer to elimination, if not to actual elimination, in this next period of time. And we've had an exceptional, and it was really a kind of unforeseen movement here at home in which 2 presidents back to back stood behind this as a White House initiative. I remember going to the White House when the Obama administration unveiled its next 5-year strategy. I think Chris was there, Bernard was there. It was remarkable to see at that level the embrace and carrying forward into the next 5-year period of a strategy, an aggressive and very well-informed strategy. It was also the only opportunity any of us had gotten to get that close to Steph Curry, who was there as a malaria activist. So, that was a particularly important moment. But we've had, as I said earlier, sustained, continuous support backed by a coalition of industry. We're joined here today by senior leadership at ExxonMobil. We have a Secretary of State in the form of Rex Tillerson, who in his tenure as head of ExxonMobil drove forward very dramatic expansion of programmatic efforts in malaria control. We have many biotechs and pharmas, active bipartisan support within Congress, strong support from the faith community, strong support from innovators like PATH, the Malaria Vaccine Initiative. As I said, 2 presidents who've done this. And the Global Fund, which got very strong reference here across the different presentations. It's very important to remind everyone here that the Global Fund grew up in 2000, the 2002 period, as an initiative with very strong backing from George W. Bush and that administration. And it deliberately embraced the 3 primary infectious diseases, and it deliberately embraced a funding formula in which the US commitment of every dollar was met by 2 matching dollars coming from other donors. And that proved to be a very powerful motivator in not just showing the concrete gains that could be made from the Global Fund investments in malaria, TB, and HIV/AIDS, but also to show that there was a combined effort over time, and that the Global Fund was operating in very close partnership with PMI, the President's Malaria Initiative. And I think, Bernard, you've made that point, that there was a sync up early in the equation that made it possible to see success. Now we're at a situation in which there's a challenge really upon this vision. Really, if you look at the President Trump's blueprint budget, it does acknowledge the special contributions made by PMI and PEPFAR and the Global Fund, as well as the Gavi, the Vaccine Alliance. Tim Ziemer has joined the administration as a lead personality in the White House on health security, all very promising steps. But there's a challenge to this community that we're in as to making the case for this as something that fits within an America First agenda. Both in terms of how does this tie back to what this White House is arguing are core interests at home, and how do we figure in terms of the management of opportunities and the management of threats. And moreover, what do we gain if staying the course in the next 4 years? I think that becomes a terribly important question. If we stay the course, which you've all argued is very important that we do, regression would unravel progress very, very rapidly, and we'd be in a terrible situation. And we have to manage things like Venezuela, which are going to be with us for some time as a crisis. So we're at this moment where, in our own budgetary process, as that unfolds, the debate is upon us around malaria elimination and eradication, the legacy of the last 11 or 12 years. Where do we go forward, and how does it fit in an America First world? So, Chris, I'm going to lay it on you to help us begin to answer that question. You've offered us some answers in your presentation, but I think we wanted, before we turn to our audience for comments and questions, I thought I'd put that broad question out and ask all of you to chip in with some answers. But Chris, maybe you could help us start that.
Yeah, so one comment I kind of alluded to in my talk that I would come back to is the critical importance of country ownership. And so the leadership has come to a significant degree from the United States and the resources. But I think PMI and the Global Fund both are to be commended for framing that support in the terms of it's the National Malaria Control Programs, it's the Ministries of Health that have to own this and have to take leadership because they're the ones who are in this for the long run. Administrations come and go, and they have to be committed and have skin in the game. And the other related thought that I think will come up again in the panel on partnership is that you don't have to wait until things are under control and health systems are stable and there's good coverage everywhere and governments are even stable. And the example in my personal experience that illustrates that is in Myanmar, which I think again we'll hear about later, where the event that we had here just short of 2 years ago, this was before the elections. This was when there were still 17 armed ethnic militias that had not signed peace accords with the government. And yet, when you got people to come together around a shared public health goal, they were actually willing in that instance, and maybe in Venezuela, if they can't agree on anything else, at least, and maybe you'd even comment, Catherine, on, I understood there's actually a physician who's been threatened for reporting malaria. Is there any hope for getting people who aren't agreeing politically to come together around a public health goal in Venezuela?
Well, I mean, first to the bilateral challenge. I mean, the U.S. and Venezuela diplomatic relationship has been strained in recent years. So the potential for sort of bilateral assistance or outreach around health or other issues, I think, is challenging. It may be better to try to work with border countries in the region or even with other countries that have maybe more constructive relationships to try to encourage receipt and willingness to take on essential medicines, to encourage to continue to support the Pan American Health Organization in working with the country and others. I think there's been, to the question that you put forward, I mean, there has been, I think, considerable interest on the part of civil society groups in Venezuela and the diaspora, outside of Venezuela to, try to come together to share what information about health that is available, to do that in a careful way that, reinforces, the idea of support for the people and for the people's access to health services, whether there's a way to kind of create an external a way of supporting that diaspora and that group internally to put forward proposals that can be aired and taken seriously, and it's not clear right now.
Bernard, do you want to say something? I realize you're speaking from a position inside the U.S. government as Marcos is speaking from a position as a member of PAHO, but nonetheless, if you could share with us your thoughts around what is achievable in the next 4 years, how do you make the best case that we stay the course and stay focused in this period?
Yeah, obviously I won't comment on Venezuela, which is a tragic, but if nothing else, Venezuela shows what happens when you have political disruption. And right. This has happened during our time in PMI. We have had similar situations in some of the countries we support. And when, for example, in Madagascar, there was what the State Department considered a coup, we no longer were able to work directly with the government, but we are able to continue to work in the country because the U.S. allows us to continue these as part of the humanitarian assistance through the NGOs and others who are there at the country level working. And that's an important piece of this. And I just want to call out again the importance of not just the important bilateral relationship, government to government, but also many of the organizations represented in this room who have a country presence and are actually at the forefront of being out in communities and working with that. I personally think that there's every reason to suspect that these ambitious goals of an additional 40% reduction in cases and deaths by 2020 are reachable. I mean, I would just point out there still are these gaps. Our present tools are not perfect. There is no perfect tool. But I think what we've learned in malaria that imperfect tools applied somewhat imperfectly, but at scale and consistently over time, you start seeing some pretty remarkable impacts. And that's the other thing, the ability to continue to show what's happening with the funds, who's being reached, and what kind of impact that's having is important. And some of these, I think where we haven't done as good a job as we should going forward, because we've been focused, those of us who are medical people always focus on, rightly, on the burden of disease, but particularly in the African setting, malaria is such a huge negative impact on the overall health system. And we're already seeing that as you start to bring down the burden of malaria, it creates more space within the health system to be able to deal with other important diseases, whether it be Ebola or Zika or whatever else might be happening. And the nice thing with malaria, if you actually do something about it, you don't need to wait years to start seeing that. You start seeing this within one transmission season. So those coming at this, the whole important agenda to improve the overall health systems in countries, you're not going to be able to do that in the African countries, at least, without dealing with malaria. And dealing with malaria, you will start seeing an improvement in health systems much quicker than you would by ignoring it. Lastly, I think what really what put malaria on the global agenda long before the Global Fund and PMI was not just showing that it was a huge global health problem, but showing that it was an impediment to overall socioeconomic development for countries. And that gets into Jeff Sachs, I'm not an economist, so so people may argue whether or not the macroeconomics of health are estimates that 1.2 or 3% reduction in GDP per year in Africa, and over a decade you end up with a 15% lower GDP. That did put malaria on the global agenda as not just a health issue, but as a development issue. We haven't done a very good job, frankly, in our systems for malaria of showing that. And we know that in countries like Malawi, previously up to a third of out-of-pocket expenditures in these poor households was spent seeking treatment for malaria. So even though we're now able to show that there's less malaria, we haven't done a very good job of showing that there's more resources for these communities now to be putting to other important things, whether it be education or other issues. So I think we can meet these 40% reductions if we continue, and frankly, to meet these, it's not just about staying the course. We actually need to ratchet up resources. Not all of that will come from the US government. There's already some indication that some of these, the national governments themselves are able to put more resources in. And then there's other people, in fact, I'll be in New York tomorrow with, there's something called the Malaria Council that Ray Chambers and some very influential people who know how to do this. I know nothing about innovative financing or Wall Street or any of this, but these people are actually thinking outside the box and how there may be some additional resources coming in. But if the US government doesn't continue, it will create a negative cycle for others to start losing interest. And the more the US government stays central to this, I think we will continue to be able to rally together and work with these countries to move forward.
Thank you. Marcos.
Just briefly, I think it will be, I think this country, the US, has tremendous opportunity it will be a waste, all the money invested so far by this country in malaria, and not to try to finish the job. Let me pick on the issue of country ownership, fully agree. But if you look at Haiti, for instance, very poor country, devastated by natural disaster, fully committed. We have a program manager that is truly on board, but they don't have the whole funding they need from the government. So still, the US can make the difference. And to me, not staying in the course and increasing the funding for malaria, which has proven so far that cost-effective interventions, and to finish the job, it will be, I think, losing on taxpayer money, because this is money well invested, in my view, from this country. So I think it is important for the partners, the US-based partners, to keep pushing that in the right way on that the benefits of staying the course are really outweigh the risk of not staying the course.
Let's take a couple of quick questions. We're getting near the end of our time, but we do want to hear from you. If we could start here up front, and we'll take a few, and then we'll come back and close. Yes, sir. Please identify yourself, and please be very succinct.
It's hard for me to be succinct, but I'll try. Steve Hoffman from Scenaria. So many of us participated in the March on Science here this weekend and around the country, and one of the things that was so disconcerting was that the message that was framed in many of the quarters was that we had one party that was for science and another party that was anti-science, as reflected in part through the administration's planned budget and the cut of 20% to the NIH, as well as aid programs and so on. And that really, this is the Center for Strategy, right? So what's the strategy? What's the message? It's not enough. We can say this over and over again, exactly what's been said here, but it doesn't, it looks like it's falling on deaf ears in a lot of quarters. So how do we go from something that seems so obvious, to at least to us, to actually meaningful intervention?
Thank you. Other comments or questions? Anyone else? Back here? Please wait for the microphone, please. Thank you.
Hi, Charles Oliver with USAID. I've been running health programs for about the past 30 years. Been involved in malaria all over the world. Remember meeting Bernard when he was doing those fascinating bednet trials in Kisumu, 1994, I think. Amazing stuff that's been done. My big question is, how have you calculated into your calculus, you know, all of our interventions on the medical epidemiology side are all very sound, all very innovative and effective, but then how do you tie this into practice at the country level, working with countries that just don't have the governments? Like, look at Venezuela, look what's going on in South Sudan now. We need to figure out a way to engage with these leaders in these countries, some of whom are maybe very authoritarian, some of them may have a lot of control, some may have very little, to try to figure out ways to co-opt them, to massage their egos, get them involved and help, because they may be part of the solution even if we don't particularly like them. And so I wonder, what are we doing about looking at governance in terms of the health systems approach? Not just how the medical services are being run efficiently, but how all of these things come together at the national level.
Thank you. We have Gina, and then we'll come back to our panelists. Yes.
Thank you. Regina Rabinovich, Harvard, East Global, and ASTMH. We've spoken, I'm very glad to hear about the potential stability of funding for PMI. I think we're all very encouraging and hoping that the Global Fund funding will continue. And I really look forward to finding out what this End Malaria Council is going to come up with, these very smart financial people. And so that has to deal with the inputs. But the other is eligibility. And whether it's Global Fund funding, I don't know how if this affects PMI, this demographic transition means that aside from availability of multilateral resources, there may be limits at the country level in terms of eligibility for outside funding. So how do we develop a mix that addresses those countries that are in transition, that is not only in Latin America, but what's emerging also in Africa? Right. Thank you.
Thank you. So we have some big questions. One on what's from Stephen on what's the strategy for this moment in trying to make the case that reaches beyond ourselves, right? What's the way in order to go against a populist skepticism around this, which is where we are today. The other is the questions around implementation and governance, and the third around countries in transition. Those are three big questions. We don't expect you all to answer each of them, but why don't we just go down the line here and start with you, Marcos, and whichever of those appeal.
Well, I think Gina raised a very good point about eligibility, and one good example is basically the Mesoamerica grant in Central America from the Global Fund, which is only one grant for 10 countries actually, because they are not eligible for individual grants. So, and in that regard, that is my appeal, to keep the global fund. You can eliminate also HIV, maternal transmission in several English-speaking Caribbean countries, maternal and child transmission of HIV, by having joint proposals. So that's a very good innovative area to deal with eligibility, in my view. And also suggesting, putting pressure in governments, local governments, to put more money on. Well, and regarding the question on what to do, I remember ASTMH came with a very great idea about writing to the senators on Fogarty when the budget was suggesting that cuts for NIH was going to be made. So I don't know if that is a possibility here, but I think there's a tremendous opportunity on the grassroots level for me here in this country to push that movement up, to take it to the Hill and to the White House. I'll pause here.
Thank you. Bernard.
Yeah, well, first of all, I think I'm not going to comment on the global fund, but this whole issue of eligibility, basing that just on a GDP of a country, I think is a mistake. I mean, again, the global fund was, if you look at their strategy going forward, is to end the 3 epidemics, and epidemic is a misuse of the term for malaria, but we'll go with that. So countries that are on the verge of actually eliminating malaria shouldn't be dinged now because they have a low burden, and in the process of doing that, maybe that's unleashed other resources so they're developing quicker. I don't know of any disease that's been eliminated from the face of the earth that's been done only with resources from the national countries themselves. I mean, look at polio or smallpox or measles or name the disease. But to link this issue that Chip brought up and Gina, I mean, I look at a country like Angola, the whole idea that, I mean, we were being questioned by people within USAID, why are you still continuing to put money into Angola when they have all this oil money? Which sort of implies that as soon as the GDP goes up, all the equity issues related to malaria are solved. And yet malaria is, if nothing else, it is the disease that is most associated with poverty at a country level. The poorest of the poor in rural areas, frequently beyond the link of not only the health systems, but the political systems. So to assume that just because there's resources, a country's resources gone up, suddenly that's all solved, I think is ludicrous. And we do need to engage in a more coherent transition plan for these countries. And there is no one particular easy answer to that, going back to Chip's point. The countries are different, who you're able to engage, how that's done. But in the process of doing that, you still can continue to make progress if you're serious about doing so, and work with all the partners of the country to continue doing that. Lastly, hopefully, there's not just one party that is pro-science. We recognize there may be a bigger weight of skeptics on one side than the other. But going back to Chris's point, I think at least using some of these major diseases and the research and the efforts going in that as sort of pathfinders, because there has been a lot of consensus in Congress and both parties around the Global Fund, PEPFAR, PMI, and if nothing else, that's a positive thing, and how we figure out how to continue to build on that while pushing forward. And there will be other election cycles.
Yeah.
So.
Catherine.
Just focusing on Venezuela and the issues around U.S. interest in the situation there. I mean, there, as I said in my earlier remarks, I mean, there was considerable U.S. investment in the health sector and in social sectors in general in Venezuela in the 1960s and 1970s. And even though the bulk of that happened several decades ago, to just suddenly say, well, now we're not interested or something would be, I think, a bad consideration of historic investments over time. Certainly, if we begin to see increased migration or higher rates of malaria that then become security challenge or economic challenges for the region, that's going to be something that creates a greater interest here as well. The question of eligibility for external assistance is one that affects countries throughout the region of the Americas, as Marcos pointed out. And the United States has in many places in the region really gotten out of development assistance for health and graduated countries from various different kinds of programs. And so I do think that's one thing that the U.S. will have to look at as it works with the region, is how to maintain relationships on health through the technical agencies and through other kinds of programs, in the event that there are, the kind of outbreaks like we saw with Zika and others, how do you continue to have strong relationships on health, even in the absence of, in-country-based programs?
Thank you. Chris?
Yeah, so I think if we want to be influential these days, we need to get on Fox News. And I don't really mean that facetiously. We've got at least one journalist in the room. We've got some media consultants in the room. It's not something that always comes naturally to those of us who work in public health or in research, but we just have to get outside our comfort zone and do it. And so we've just hired our first full-time media person at our institute. And I think we've got to find people who can tell stories and get attention and inject some drama into it. And the malaria community has done pretty well with that. Several years ago, you could have George Clooney answer your questions about malaria in the New York Times. And I think that had a lot to do with those trends in support and how it got people's attention here in Washington. And then finally, I think we really have to push back against any temptation to make malaria eradication a political football. When we were working in Myanmar, when sanctions were still in full force, the people at the State Department who were the most rigid on sanctions said, oh, well, that doesn't apply to you. You're doing something important in public health, and we'll bend over backwards to make an exception for you and get people and goods in and out and so forth. The same would go for Venezuela. I've even tried to reach out to the WHO office in North Korea to no avail. But I think we'll work with institutions with dismal human rights records if that's what we need to do to make progress on malaria. And I think we just have to keep doing that.
Thank you. Just to close, and we need to move on to our next panel, a special plug for the Fogarty International Center. I think we need to recognize that indeed that is, while it's a small institute at NIH, it's terribly important in connecting us to the rest of the world. It's done a remarkable job, and it needs to be sustained. I do agree that, we had a great demonstration this weekend of the faith in science. I didn't think it was particularly partisan in its outlook. I thought it was remarkably pro-science in the approach that was taken. And I think the best case to get back to Stephen Hoffman's question, I think the best case, we've heard some answers to that. I think it's all about U.S. leadership. It's about leadership in science and innovation. It's about leadership in laying the basis for stability and prosperity and security. It's about dealing with a world of interconnected humanitarian challenges and developmental challenges, and doing things that are smart, that have proven rewards, and which build on the investments that have proven themselves to be really high value. That's all based on, I think, a sense of common sense and vision of how the U.S. plays in this world. And this, I think the topics we're talking about here today fit very, very easily in that world. On the threat side of the equation, I don't think it's going to be hard to make the case to this White House or to this Congress about the challenges that Venezuela poses and the need to be very creative. And the United States is constrained in some very real ways in its direct abilities to respond there. But we have many other tools and many other partners in dealing with the consequences in terms of health and humanitarian disasters and migration and the like. And I think that's going to be with us. So please join me in thanking all of our wonderful speakers here this afternoon. So we're going to transition.
made a couple of key points that we need to consider in terms of this panel. The first is that there's really a continuum between all of those activities that are required for control and the country's aspirations and their activities to reach elimination. And the reality is, while we talk about it as a long-term goal, 7 countries have been certified in the past 5, 6, 7 years. Sri Lanka is, I think, really symbolic of that, a country that had resurgences and decided the only way to do this was to eliminate, because once elimination is achieved, it's remarkably stable. The second is that we can talk about plans here and about funding programs, but it's country aspirations. And right now, WHO has identified 21 countries that are aiming to have at least 1 year of malaria-free status by 2020. If you had told me in 2007, when we began working and talking about the word elimination and eradication, that's where we would be, I would have been surprised, to say the least. And so whether all these countries reach it, that's their goal. They're now getting together as a group, they're problem solving, and they're doing that with existing tools. Now, the goal of this group is to talk about innovation, but the third point I want to make is that while the tools we're using right now, rapid diagnostic tests, long-lasting insecticide-treated bed nets, longer-lasting insecticides that overcome resistance for endoresidual spraying, and the new combination drugs are the standard. In the year 2000, which is when I date malaria, because that's when I started getting involved, none of those were being used. And none of those were being scaled, even where they were available, or data to support their use was already available. So there's clearly a part of innovation which is about conceiving the idea to solve a problem that you're facing in the field. And then there's another part of innovation which is about financing and use in the field, because if you don't link both of those pieces, you will fail. Now, this group represents 4 very different sectors, if you will. Some of them have several hats or heads. I haven't quite figured it out because they've been in different places, as have I. Lee, actually, you've been at NIH the whole time, playing a number of different roles. Steve, you've been in DoD, the Navy, private sector, and have pushed that agenda for your entire career. Patrick, you've been at CDC and playing, again, different roles. And then Larry, you've escaped CDC, and now you're at NGO, again, playing still a malaria role, but from a very different perspective. So what we're going to do is have them open up with 5, 6 minutes or so, talking about how you're pushing and engage in innovation from your individual spheres. And then I'll ask some questions, and at the end, we'll open it up for questions. So please do be collecting those as we go along. I would suggest we start out with Patrick. Not only because you're sitting with me, but that was the plan.
Well, thank you, Gina, and thanks to CSIS and ASTMH for inviting me to be part of this panel. I really enjoyed the first session and hope we can live up to it in the second session. I'm the malaria branch chief at CDC, and I sometimes try to put it into perspective by saying that America's fight against malaria started at CDC. But that's actually a little bit backwards. CDC was started as a result of America's fight against CDC. Okay. Chris showed that map of where malaria was endemic at the start of the 20th century. And when World War II broke out, a great number of the US military training facilities were located in southeastern states in rural communities where malaria was still endemic. Even before they got to the Pacific, servicemen were becoming infected and ill with malaria. And so it was a matter of national security to help the state and local health departments in the southern states eliminate malaria. CDC still views that domestic responsibility as foundational in our malaria program. And we focus on 3 levels of malaria work: our domestic responsibility to protect Americans living, working, and traveling abroad, our bilateral responsibilities supporting US government bilateral programs through PMI in malaria endemic countries, and our multilateral support, our status as a member nation of PAHO and the World Health Organization keeps us in close contact with them, and we contribute technical expertise to their various strategy and planning groups. I guess those things aren't always distinct either, and in a way, you can look at a response to how do you balance the importance of what we do in an America First environment, and I think you can underscore some of the linkages between the domestic and the global. And Alan's career in particular reminds me of how important and how interlinked those two things are. Some of the recent work that we've been able to do that I thought about in talking with Gina and preparing to come up here is work around anti-malarial drug resistance, a really crucial issue. Through PMI support and indirectly through WHO, we work with endemic countries to study what drugs are working and how well. We do this through pretty detailed on-the-ground studies where you enroll patients, treat them for malaria, and bring them back for weeks to see whether the infection has been cured and whether they get sick again. But we can only do that in a limited number of places. PMI has helped us greatly expand that network, and so in about 30 countries, US government scientists work alongside endemic country scientists or non-government implementing partners to collect that important information. That helps us decide what's the best drug policy for those countries. It also helps us shape the advice we give to Americans when they travel abroad. Starting in 2014, we started using resources at CDC through the Advanced Molecular Detection Program that HHS had funded. And we used that to more thoroughly interrogate the samples we receive from patients diagnosed with malaria here in the United States. As a reference laboratory, we provide support to state, local health departments, and hospital labs that are challenged to diagnose malaria as they see it so infrequently. And we've been able to look at the genomic makeup of those infections and look for drug resistance markers, look for the signatures of the populations in different parts of the world, and begin to piece together a picture of how parasite populations move and evolve over space and time, and look at trends for drug resistance. That gives us insight, that expands our insight from those 30 countries where we are looking on the ground to over 60 countries in the last year, and we're really just getting started with using this tool. I think when we look forward to what kinds of innovative work we want to be part of at CDC for malaria, especially with an eye towards elimination, we focus on 4 main areas. The first being to improve surveillance, improve the collection and use of data that will help know where to deploy resources and how to identify the last foci of transmission. We look at work to mitigate threats to our current generation of tools, insecticide and drug resistance, or parasites that can evade the most commonly used diagnostic tools that we have available. And we look, thirdly, to being part of developing, proving, and learning how to implement new tools, new diagnostic tools, new drugs to overcome resistance, but also ways of taking those diagnostic and treatment tools beyond the clinics into communities, or beyond the situation where someone's ill, taking medicines and using their properties to reduce the burden of malaria, even among populations who aren't yet ill. And a third element, or a third new tool that would really be promising for us would be to have a vaccine that we could take to scale. We were happy to be part of the RTSS clinical trials, and WHO announced earlier today the pilot implementation programs there. We're also working with NIH and Scenaria, my panelists immediately to the right, to test the whole sporozoite vaccine in infants in Kenya. And we think a vaccine and new drugs, new diagnostics, and new vector control tools could all really change the mix of what works for us.
Great, thank you very much. Well, since you've brought up vaccines, let's jump over to Steve, because he's really committed his career to figuring out how on earth we're going to make a vaccine. And many people do believe that a vaccine is going to be critical, particularly for the highest endemicity areas. Stephen.
Thank you, Gina. So before I get to the vaccines, I'd like to talk a bit about malaria. So can anybody tell me, the Salk vaccine for polio was introduced, I believe, in 1957. How many cases of polio was there in the United States the year before, and how many deaths? Anybody have any idea? Well, there's 13,000 cases of paralytic polio and 1,000 deaths the year before the vaccine was introduced. The WHO embarked on the World Polio Eradication Campaign in the mid-'80s, I think it's 1988. And does anybody know how many cases of polio there were in the world the year before that? There was 360,000 cases, estimated, with about a tenth, maybe 1 in 10, 1 in 20 associated with death. So last year, in 2015, depending upon who you read, you can read the World Malaria Report, said there was 438,000 deaths from malaria and 214 million cases. You can read the Lancet, which said there were 660,000 deaths from malaria. Or you can read the New England Journal of Medicine that said there were 730,000 deaths from malaria. And by the way, that's a pretty big difference, 300,000 deaths between two different estimates that, of course, have confidence intervals. So the magnitude of the problem that we are trying to address is very different than the magnitude of many of the other problems that we've been successful with. And we need to think about that. So Saturday night, I was at a banquet for the American Association of Physicians, a group called the Old Turks in Chicago. And the after-dinner speaker was a very prominent public health individual. And the topic was innovation, which is what we're talking about here today. And she talked about small I and big I. And the problem with the biomedical research community over the last several decades and the way that we get funded for research is that what we get funded for is small I research. Now, a lot of what we do in malaria has to be small I research. It's iteratively going further and further for innovations, but these are not big innovations. They're not game-changing innovations. And I would just say, for a few examples of, we talk about the success, but we have to remember that in the 1930s when Anopheles gambiae entered, sorry about that, entered Brazil and caused incredible morbidity and mortality, a team led by Fred Soper from the Rockefeller Foundation eliminated every single mosquito Anopheles gambiae from the country before there was DDT. So the kind of things that we're trying to do are very doable. Gina mentioned the celebration that we've had in the last year that Sri Lanka eliminated malaria from Sri Lanka. But in 1963, Sri Lanka had 17 cases of malaria, 11 of which were imported. So it's a pretty fragile environment. Now, 5 years later, because they gave up the job, they had more than 1 million cases of malaria. But that's doable. The kind of things that we need to do to get at it, are small I innovations. I like to tell students about a case that I had when I was studying cerebral malaria in Indonesia and West New Guinea in the early 1980s. And I got called at 2 in the morning to see a 3-year-old girl who had been kind of stuporous and so on, but had gone into coma and dropped her blood pressure. And I went to see her, and she was cold and clammy, and I immediately diagnosed hypoglycemia, checked her glucose, it was 0, gave her 50% dextrose and a 10% dextrose infusion, and walked away with my colleague, a pediatrician, and said, if we hadn't been here, she would have died. And 2 hours later, she died. Okay, and that's the story of malaria over and over and over again, and it was the story that kind of eventually led me to go into vaccines. I had an intervening experience, which was really quite great. I worked on the island of Flores near Timor in the center of Indonesia. And I had worked there for 5 years, and I felt a responsibility to the community. About 50% of the 2 to 4-year-olds had parasitemia, or 2 9-year-olds every time you went there. And so I convinced USAID to do a village-based malaria control program in which we trained a cadre of individuals, village elders, under the direction of the head of the village to spray the DDT that we had drop shipped in there every 6 months, do some source reduction. There was a mother's group that met every Monday night, and we had them talk about taking kids in to be treated. And within 5 years, we went from 50% cross-sectional prevalence of malaria every time you did it to less than 1%. And then, I was long gone at that point, and then what happened was that the program funding stopped, and the next year there were more cases of malaria with deaths that we didn't have before. So malaria is fragile in many places in this world, and there's so much that we can do, as evidenced by the $3 billion that were invested last year, or more or less. But with that, we had more deaths than there were ever cases of polio in this world. So this is a big problem. So what we've tried to do, recognizing that all of the work that is being done is so brilliant and so wonderful with such dedicated people, is try to completely bypass it with a big I approach. I hope it's big I, which is to make the first, there are no licensed vaccines against human parasitic infections. And so that's what we're trying to do. We're taking an approach which, up until now, and when we've been able to compare it to any other approaches, is significantly better. And I would just leave with the fact that we had one of our closest collaborators is Professor Marcel Tanner, who is the president of the Swiss Academy of Sciences now and former head of the Swiss Tropical Public Health Institute. And he gave a lecture at Scenaria 2 weeks ago, and then spent the weekend with him, in which he wouldn't stop talking to me about this, is that we're all wrong in the way we're thinking about even implementing vaccines and testing them. If we go along iteratively the same way that we have, what he's saying is, you have something that works. It's been shown over and over now that it works. Let's use it. Let's use it along with all the other interventions and see if we can get to the end game in places, some of the places even like, say, in Zambia, where there's this great heterogeneity, where mass drug administration has taken us very far, but it's clear in the higher transmission areas it may not be enough. So why not go in right now with a tool and figure out how to use it in a regulated fashion? But if it's been shown to be safe, well-tolerated, and highly protective, why not just use it? And that's going to require big I innovation and thinking in other arenas. And so I think that we can go on, and we are making incredible progress with the tools that we have. and keep iteratively improving them and keep applying them. And we need all the work on policy and funding and good people on the ground. But I think that some have to get funded to do big I work. And I'm not saying we're the only ones, but big I work that could be groundbreaking. And of course, we all hear about Gene Drive, which could be a big I type of game-changing intervention. But we need that too. And one of the things that Chris said at the outset is that in a lot of forums, the research is not funded. And it shouldn't be all of it. At the meeting that in 2007, when Bill and Melinda announced the goal of eradication, I actually got up and said, why can't we spend 10% of what the faith communities or whatever, put that on research also? Because it's only by doing that that we can get these big I. There's only big I changes. Thank you.
Thank you. That was the best talk on vaccines, which you didn't talk about vaccines. So that was very interesting. But what you were doing was actually making the case for why big I was needed, and that vaccines and thinking about vaccines requires that. So let me jump to Lee. Because
I knew this was coming.
Well, because we'll get to the rest of it, but he's talking about big I, and that's really what NIH does, right? And you've been engaged in malaria. You've got your own strategy that you've been implementing over the past decade. You funded units that are focusing on this. So tell us your story. What are you driving forward from the NIAID perspective?
So let me sort of just...
You're not going to talk about NIH now?
No. I'm going to talk about NIH.
Yeah,
I'm going to talk about innovation, big I and little I. And I just want to sort of go back to something that several speakers have said, and that is that I really think that one of the most important messages we have is that with the current tools that have been applied judiciously, we have made tremendous progress over the past 15 years. But I think that to address a number of points that have come up, if we probe a little bit more deeply, we have to sort of say, well, what does the future hold? Because Alan McGill and I used to have this back and forth discussion, and he had this analogy drawn from, I think it was Alice in Wonderland or Through the Looking Glass, where he would talk about Red Queen, the Red Queen syndrome, where basically you have to keep running faster and faster to stay in the same place. And that was the concept. And we would get into discussions about, we've made tremendous progress, but if we're going to maintain that momentum, that direction, how are we going to do that if we have to keep doing more and more? And the question comes down to, well, why do we think that we have to run harder and harder? What's holding us back? Why can't we maintain the same trajectory? And in part, the answer is that as we roll out these interventions and think about what's going on, to some extent, we've missed the boat on some things. And that is that the interventions themselves actually exert incredible selective pressure on the parasites and on the mosquitoes. Mm-hmm. And so we really need to think about that aspect of what we're doing. And what that really does is argue for the fact that we need to be thinking about new sets of interventions, not just what we've been doing before, but thinking about whole new ways of approaching the problem. And in that context, the other aspect that we need to think about is how do those different interventions interplay with each other? So, if you're thinking about big I, it's not just big I in one area necessarily, it's big I in a number of different areas. Because we want to try to get around this issue of selective pressure to the extent that we can. And one of the best ways to do that is to have multiple different ways to approach the problem. So when I look at this problem, and this is a topic of, I would say, daily discussion about what can we do better, how can we think about it differently. I think that, again, you know, we really do need to think prospectively. I would just, historically, the lesson is that if you just think about malaria eradication as a technical exercise, it's not going to get there. You have to have a component of surveillance and research to understand how the situation is evolving. It's much more dynamic, and so when we think about new interventions, we think about that dynamic nature. So the way we've approached this is, first of all, we think a lot about the basic science and how that can inform what we need to know going forward. So we've made tremendous progress in genomics and in understanding the genome and the plasticity of the genome. We have incredible sequencing technology now that we can apply, and that's helping us a lot with the types of things that Patrick was talking about, gene flow. I would just point out that Steve was actually one of the people who was pushing for the falciparum genome when genomics was just beginning to get started. And that was actually quite visionary, and I think that was Big I. Wouldn't that count as Big I? At that time. These days, we can do sequencing, it's only little I now, but it was Big I at the time. So then we think about those types of interventions. The other thing that's happening is that there's been continual progress, and as we look at these different modalities, can we bring them in to solve what is predominantly a disease of, it's seen as being, it's a global disease, but it's of resource-constrained environments. And so we want to be thinking about what are the implications. It's great to have very high-powered, expensive technology, but if you can't get it out there and used, you have to sort of reconsider your strategy at that point. But getting a proof of principle is valuable. And then the other part, which I think is really critical here, is looking downstream. I've already alluded to the fact that you want to think about how these are being used. If you go out to the field, one of the issues that we identified early on was that everybody was working with laboratory strains of malaria, and they were doing very conventional things. But when you went out to the field, for example, vaccines didn't perform as well as expected compared to animal models or compared to human challenge model. Why was that? And so there has to be a much greater dialogue and much more multidisciplinary research that goes back and forth between what's happening in the lab and what's happening in the field. And thinking about it just from the standpoint of product development going from laboratory to field, that's fine, except that what you really want is to know what's going on in the field so that it can feed back into the lab and say, you know, if you go along with this, you're not going to have the effect that you want. So let's think about it differently. It's much more of a dialogue. So when we look at all of these interventions, we basically think about them in, from the standpoint of the 4 Ds. The 4 Ds are discovery, design, development, and then either delivery or deployment, depending on your particular choice of word. But if you start thinking about it that way, and even though you're in discovery and you're thinking about, well, what can I deliver? That changes the way you think about these things. So we've actually, you know, put our money where our mouth is. We just recently announced the recompetition of one of our lead programs, which is designed to bring this sort of multidisciplinary dialogue back and forth between the field and the lab. We're very excited about that. And we provide a whole series of support services for development of new drugs, vaccines, diagnostics, and vector control interventions. But what we're ultimately interested in knowing is, are those things that we're supporting going to be useful to people in the field? And what are the people in the field? What are the conditions out there that would support their further development? So I can go into more detail perhaps in the question and answer, but I think that that's sort of an overall answer.
Great. Thanks, and thanks for setting that stage for Larry, where for the past decade, the PATH teams have been involved in taking individual innovations and tools and thinking about how to use them in a different way that's targeted, first of all, to scale up and then to elimination. Can you report on what's the latest with that and what you've learned and where it's going?
Sure. Thanks, Gina. And thanks to CSIS and ASTMH for inviting me here. So I'm not going to talk about big I or little I, I'll talk about big Z. So I want to talk about Zambia for a moment because that's a country where PATH has been working very closely with the government of Zambia and the Ministry of Health for well over a decade. I think it's a great example of what's been achieved, as many have alluded to, and then report back from the field on what sort of innovation and discovery is sort of most useful for people actually working on elimination in the field. And before I talk a little bit about that, I just want to introduce three colleagues from Zambia who are sitting at the back table here. Dr. Busiko Hamanza, who's an epidemiologist with the National Malaria Elimination Program, Ms. Miriam Banda Chisamba, who's a midwife working in the ministry, and Mr. Morgan Sakala, who works at the provincial level on controlling malaria. So please take a moment to talk with them later on. I think you'll find their work inspiring and interesting. So it's been already alluded to, Zambia has been really a leader in malaria elimination in sub-Saharan Africa. They were the first country to introduce ACTs, one of the first countries to introduce RDTs, and they were very aggressive and focused on scaling up those interventions and insecticide-treated nets, of course, and had a remarkable reduction in child deaths. But they weren't content to say, well, okay, we've done well, let's watch malaria decline slowly. They wanted to know, how can we accelerate and what can we innovate to accelerate towards elimination? So working in Southern Province in Zambia with PATH and other partners, the Ministry of Health sort of led the effort to scale up these interventions, not only including the drugs and the vector control, but also surveillance, and surveillance not only at health facilities, but surveillance out in the community using community health workers who were not only testing and treating, but were also reporting back and collecting the information on where people were actually coming down with malaria. And then adding on top of that, mass drug administration as an accelerator to reduce the parasite burden in the population, and then hoping that the surveillance and response activities could then sort of mop up the last bits, because you can't maintain mass drug administration indefinitely. It's a means to an end, it's not an end unto itself. And so that was quite successful. There was about a 90% reduction in malaria infection rates in Southern Province, and now Zambia is taking that approach and scaling up nationally. They have very ambitious elimination goals over the next 4 years. That's all predicated on very strong national leadership, including a commitment to spend a lot of their own domestic budget on malaria. I think the highest, at least per capita amount of any country in sub-Saharan Africa, $25 million last year of domestic resources on that. So they've had that kind of effort, and I think it's exciting. But so what are we learning from the field, and what is it we need to really focus on to continue to make progress towards elimination? Well, vector control is great, but of course the insecticide resistance issue has already been raised, and it's true in Zambia as well. And there are some new products in the pipeline. New insecticides, new nets. But the other thing that's we're observing in Zambia is that as we deploy these indoor focused vector control interventions, of course, there's a shift, as the mosquito and the parasite always do. They evolve in natural selection, and now there's more outdoor biters. So if we're going to address that, and we have some entomologists in the audience, so I have to say this because they'll attack me otherwise if I don't. But indeed, we need to figure out ways to address outdoor transmission better. And there are some products that are in the pipeline that should be evaluated in the near future. One of them is called attractive toxic sugar baits, which always makes me hungry when I say it, but I think it could be a promising tool, and we need to focus on that in the near term. Surveillance and response has already been mentioned, and it's not necessarily a sexy topic, but Patrick's mentioned it, Lee's mentioned it. Zambia is really leading the way with a variety of partners, both in the IT and in the sort of data analysis and software world, to sort of figure out how can we best rapidly collect, analyze, synthesize, and visualize this information so that we can act quickly and efficiently to target, foci of infection. And that is, it's an iterative process. It's critical, and as we know, for every elimination program, in the end, it's going to come down to surveillance. So the better we can get at that, the better we'll do. Diagnostics have been mentioned. We have a new tool coming out very soon. It's called a highly sensitive rapid diagnostic test, about 10 times more sensitive than our current RDTs. How are we going to use this most efficiently? How are we going to use this tool to find infections and eliminate in a way that makes programmatic sense? I don't think we really have that worked out yet, and this, I think, is an area that Zambia and others can help us discover and lead the way on. The other thing that Lee mentioned and others is that, yes, the parasites keep evolving. Now parasites are evolving that are not, don't make the proteins that work with our current RDTs. So we're going to have to develop new RDTs that allow us to detect these parasites. Fortunately, they're not so numerous yet, but as we continue to use the current RDTs, we're going to select for these parasites with that mutation. So that is an area that we need to do some near to midterm work on. P. vivax has been mentioned. It's not something that we have in Zambia, but it is an infection, it's a parasite for which we need a good diagnostic test for G6PD deficiency, an enzyme deficiency that can be very dangerous in people for whom you want to treat completely for P. vivax, and you can't really treat them well if you don't test them first and make sure they're not deficient, otherwise you have a bad reaction. And that test is something that will help us, once we have it, to really move forward on the vivax elimination agenda. The vaccine has been mentioned. The RTSS, Patrick mentioned, is now moving into its pilot phase, looking at safety, feasibility, and operational and mortality reduction in 3 countries, Kenya, Ghana, and Malawi. And that will be interesting to see how that plays out over the next few years, and thinking about how that vaccine might be paired with other tools, such as mass drug administration, moving forward in further exploration of its use. And then finally, just a shout out for our socio-behavioral scientists. A lot of what we do is based on community engagement, community mobilization, and we have interventions that absolutely require the community demand, buy into, and want to do vector control, to do mass drug administration, to do surveillance at the community level. And I think we have things to learn in that vein in terms of doing that better. We can learn from other elimination campaigns, polio, onco, and so forth. But I think malaria needs to also add to that body of work. So I'll stop there.
Thank you. I'm thinking back to 2007, where I think many of you in the room were at the malaria forum, where the press the next day said, what? And the question, I think they were talking about eradication, is it elimination? And you will note that this symposium is called the Eradication Symposium, because that's really what Alan was focusing on, and the longer term goal. How has the ability to talk about that as an endpoint changed the R&D agenda, whether it's little I or big I? Would any of you like to comment on that? Stephen.
I think it's changed to some extent the discourse, but I don't see it changing. The problems still remain the same, and as such, that was a big day, and everyone made such a big deal that eradication, and it was eradication, it wasn't elimination in 2007, because we've talked about elimination in different countries for a century. So it was talking about eradication. And, quite frankly, to me, it didn't, a lot of people, and maybe even at a forum, I'm not sure it was here, but there was a lot of resistance. This is going to screw everything up. You shouldn't be talking about things you can't do, and so on, as opposed to having a vision for what you have to do. So I don't see, we talk about how we might use a vaccine in an elimination campaign, but it's still an elimination campaign because eradication requires systematic elimination. So I'm not sure it's changed the R&D agenda myself.
Okay, Lee, you're thinking on that?
Well, I'm not sure that it hasn't not changed the R&D agenda. But I think that, to me, the most important thing I think that happened there was a certain timidity around the discussion about eradication. People were very cowed by the failure of the program in the 1960s, and so nobody really wanted to talk about eradication. They talked about elimination, and sort of under their breath they'd say, and eventually we might get to eradication. But I don't think that they were really putting it out for further discussion. I think the thing that changed was that it suddenly became okay to start thinking differently, because what eradication really did was there were people who were working on transmission and on sexual stages of malaria. But I think that was a little bit in the backwaters. And that started to become much more of a focus as people started to think about what are the possible interventions, and as they started thinking about that, they realized that we really know much less about the gametocyte biology and what's involved in transmission than we did before. So than we thought we did. So they actually started to emerge, and it became a very exciting area. And what I can say that we've seen at the NIH is a lot more interest in people talking about gametocyte biology, what's going on. This was certainly aided by a number of the technologies, genomics and things like that. But that was certainly something that started to come to the fore and became much more of a focal point for discussion. I think the other thing, and this was alluded to a little bit, was that people started thinking about Plasmodium vivax and non-falciparum malaria and malaria outside of Africa a little bit more. Because if you're going to be dealing with these forms that have these relapsing stages, you have to think a little bit differently about what's going on. And you think about what's happening in the liver. And it's interesting, one of the things that I think is really interesting is the fact that primaquine works both against gametocytes and against liver stages. So are there some parallels that we might sort of capitalize on? Maybe, maybe not. But that's certainly something that is kind of interesting to be thinking about. But then related to that is the issue of, well, what causes reactivation of hypnozoites? And how does the parasite know? And so there became much more of a discussion in the scientific community about the sort of overall parasite biology of relapsing forms and so on. So those were just some of the impacts.
So let's shift the discussion around, because there is no end to intellectual curiosity, the need to understand biology, and quite often people aren't seeing the relevance that you're talking about between tackling the gametocyte, understanding how to get to the parasite in the liver, et cetera. As you think about work that you think is a priority, whether you're doing it or someone else is doing it, what do you think are the biggest problems? Maybe we need to put that up front. What are the biggest problems that you think innovation should tackle? And you're all working in the field with partners, et cetera. Who would like to take a stab at that? Steve?
I would go back to what I said earlier, which was that we've had in our hands very effective tools, as evidenced by the elimination of Anopheles gambiae from Brazil, the near elimination in Sri Lanka in the 60s, and now this systematic elimination in places particularly where malaria is less fragile than other places. Sure. So we just did a study in Mali where we took 100 adults and we treated them for malaria. Half got vaccine, half didn't get vaccine. And this is with the people who have had lifelong exposure to malaria. Anybody want to guess what percentage of the adults with lifelong exposure to malaria got reinfected in the next, it's actually 10 weeks, but let's call it 6 months? Any guesses from the audience?
A lot.
This is a malaria thing. You're supposed to try to engage here. Come on. 70. Anybody else? 93%. Okay? This is in a place where they have bed nets in the houses. We went to the houses. They have bed nets. They have ACTs, they have RDTs, and 93% of the adults got reinfected after being cured of malaria. Most of them within the first 8 to 10 weeks, because we timed the cure to the epidemic of malaria that occurs in Mali. All right? There isn't any other infectious disease on this planet that's like this. We're doing a trial with Patrick and his team in Western Kenya. This is where bed nets were truly established, the Asembo Bay Project. And from thence, we made the decisions to use bed nets all over the world. 30% of the infants that come in can't be immunized that day because they're sick, and most of them have malaria that day. This is in a place where there's bed nets, there's spraying, there's ACTs, there's RDTs. So yes, we are making incredible inroads in many different places, but if you go to the heartland, these kind of places, I would hope that we can overcome things with the tools that we have, but the hubris of that, the presumption of that, given where we are, it's 2017. This isn't 1912 or 1950s when they were doing the malaria campaigns. So I think that the problems that have to be addressed is trying to come up with big-time solutions, because we are going to have donor fatigue. We never know what's going to happen where's the next Venezuela, or where you might get administrations that don't want to support things. So
you're defining residual transmission, right? With optimal bed nets, optimal LLIMs, right, and actual treatment, that things will improve, but that there is continuous transmission, particularly in areas of high endemicity and high vectorial capacity.
And where there's political instability and poverty and so on, that's not necessarily going to go away by itself either. So that we must continue to apply what we do, but we must continue to strive for big time, as I said, big I type of innovations. I happen to think that a vaccine that really prevents infection, which will prevent all disease and transmission, is the way to go. Tying that to a vaccine that also prevents transmission is additive or synergistic. So we have to be thinking bigger ways, to solve these problems, whilst we're applying all of the wonderful tools that we have by the wonderful people who are dedicated to doing that.
I think Patrick wants to make a comment.
Well, I think if we look back at what's been so successful in the last 15 years, it's rolling out the ITNs and the ACTs, but in a way we're creating an opportunity to become victims of that success. And what has inadvertently happened is that we've put bed nets out there that are universally use one class of insecticide. And so we have pushed that product or that class of products out further than it has been, without as much thought perhaps as we could have in retrospect to how you disrupt that. How would you use what little resources or what additional resources you have for IRS to apply different chemicals to disrupt that pressure. The same thing with drugs. It's advantageous for a national program to select one drug as its first line and make that available to everybody, because that's what looks like being fair and equitable across the board. But the problem with that is it doesn't create, in some ways, when we had a more chaotic situation and people were prescribing willy-nilly, there was less opportunity for resistance to take hold. Can we be more deliberate about how we deploy the tools we have in ways that mitigate against the further spread and evolution of threats like resistance?
I think it's great to use the word mitigate, because what I have problems with is using the word prevent. And given the diversity of the parasite, actually for piperacin, there actually have been identified strains way before piperacin was used in Asia that were already naturally resistant. It's part of you're selecting for variants, and that can be one of the pathways. It's clear that it's basically applied population genetics. You drive it down at a genetic level, you're going to have variation of escape mutants or natural variants that are resistant. So that's a natural consequence of the interventions that we're putting in place. That being said, I think resistance and residual transmission are actually the two big challenges that we're facing as these programs are scaled up. Now, the challenge is not to say, woe is me, and walk away, but then figure out how these are problems that get solved. And some of it has come from innovative vector tools that don't target the same, whether it's an insecticide or a drug like ivermectin or toxic sugar-baited traps. Is it now sugar toxic? Whatever. Those traps with a toxin in it that work in a different way but that are compatible. Can we think about can we begin to visualize what the malaria elimination strategy or hypothesis 5 to 7 years from now is going to look like? We're going to have more sensitive diagnostics. If Steve has his way, we're going to be able to think about a vaccine, and we'll have data to support its use. We're going to have, based on the MMV pipeline, new drugs, because they're in there and they may last longer, they may require fewer doses. That would be great. And so there's innovation coming along right now. It's not something that isn't being worked on. Can we take on all of this change? Larry, you spend a lot of time building up a program and it knows what it's going to deliver, and everything's going to change. Can you handle it? Can the countries handle it?
Well, yeah, it's the countries, of course, that are going to be handling it. And I would say, what's it going to look like? Well, I think we want to have these newer tools. We've had a good run with what we have now, but clearly we don't expect them to last forever, and they won't. So we will need to do the field work and the programmatic evaluations to look at how we can best use some of these newer tools coming out. I think that as we build the information collection systems that tell us better where malaria is and where our interventions are, then we can be more strategic. The World Malaria Report, the most recent one, had the section on case management was quite revealing, and we've made great strides. We have ACTs and so forth. About 20% now coverage with ACTs writ large in sub-Saharan Africa in terms of kids who have malaria who actually access an ACT. Well, we're not going to eliminate malaria if we have 20% coverage. 70, 80% coverage with ITNs and IRS is fantastic, but case management is a huge area that is in great need of improvement and figuring out the ways to use the diagnostics, the drugs, and the delivery systems and the surveillance information to improve that coverage is going to be absolutely critical.
Anybody else?
So I think there are a number of different areas that have been touched upon, but I would say that one of the things that is happening now, but we clearly need to do more of it, is to apply more of the molecular tools in the field so that they inform what is happening in the labs. We can actually have an increased chance of developing field-appropriate interventions. That's one thing. The other thing that's happening, and we've alluded to it, but I think it's worth spending a minute on, is when we roll out these interventions, it's not just a question of waiting to see resistance or this or that. The interventions themselves actually work pretty well. Yeah. And so then we start to see epidemiologic shifts, and populations that might have been a relatively small component now become a major component. And so we have to rethink and recalibrate our strategy as to where do we target these interventions. I think that accelerating the development pipeline becomes really critical. There are sort of two ways one could think about it. If you want to develop more products, you can basically bring things through faster, but you can also expand the inputs that are coming in so that even if you had to go at the same rate, your chances of coming up with something successful at an earlier stage would improve. And then I think that there is value in looking at platform technologies and approaches that cut across many different approaches. For example, one of the things that I'm actually very excited about with the attenuated vaccine that Scenaria is working on is the fact that a lot of the technologies that are being developed for that ultimately will play out for all of the genetically attenuated vaccines. So that, while Steve has his vaccine that's moving forward, and we're looking forward to seeing that move into the clinic and beyond the clinic and so on, there may come a time when we want to see the next generation of that, and it may come from a variety of different genetic manipulations, but we're still going to have to use the same types of technologies for manufacturing. Similarly, if we look at subunit-based vaccines, some of the preconceived notions we had about what made for a good vaccine candidate are now being turned on their head by virtue of the fact that we're getting more experience with RSV, for example, and understanding that if we're trying to disrupt receptor antigen interactions, that in fact there is a single stable state, but one of the mechanisms of immune evasion is to have this sort of floppy molecule. And what we need to do is to think about identifying what is the right state for that molecule and then locking it in so that we can elicit a very robust immune response to it. And that we don't have to wait for naturally occurring immunity to tell us that. We can actually do some things more prospectively. So there's a tremendous amount to be learned from these technologies that would all go forward. And while individually they may be little I, we hope that cumulatively they're going to be really big I.
So let me ask you, can I ask one question of Lee? Why do you think it is that other than GlaxoSmithKline, which supported RTSS, no other major pharmaceutical company has, to my, probably invested more than $1 million or $2 million in any malaria vaccine development? Given the magnitude of the problem, given what a big I, innovation could truly mean for the world, why do you think that is?
Well, that's a very good question, and I think that we probably ought to be talking with the companies more about that and finding out what it is. I suspect that this is a classic example where they looked at the markets and they were afraid that they would not achieve a sufficient market return given the challenges of creating a particular malaria vaccine.
But that
That's
question
one
is
thing.
actually a broader one in terms of the number of innovative companies in the vector space, the number of companies that may not be engaged in vaccines but are engaged in drug development. It's in spite of the fact that you have 218 million people that need to be treated, it's still a challenging market because we don't want to pay that much per dose, so there's limited return on investment. It becomes something where you're thankful that they're engaged at all, but that there are companies for the other targets.
Right. I will say,
you're both talking to companies fairly routinely. Why do they fail to engage is an interesting problem, particularly for vaccines.
right. And I think that in many cases, they look at it and they ask from the standpoint, well, is this scientifically or technically ready for what we want to do? And so part of our strategy is to explore a number of different options and try to scientifically and technically de-risk those projects so that companies will look at them more favorably ultimately.
Because they tend to do development, but not less of innovation to really discovery. Let me open this up and see if there are questions. Michael McDonald, you've got the...
So I think you can anticipate this. So Larry, thank you for mentioning the mosquito. But to follow up on Regina's point right now about innovation in the vector space, I don't know, many of you probably saw the excellent article in the New York Times yesterday, which was why the menace of the mosquito will only get worse. And so strategically, the question is, can we tie entomology for malaria for the great drive for Zika and other vector-borne diseases? I think strategically, we're missing an opportunity here to I know we're not roll back mosquitoes, we're roll back malaria, but can we use this opportunity to really drive the profession of entomology and vector control?
All right. Let's take a couple questions, then we'll go. Right. Yes, please. You need a microphone because otherwise people can't hear you. Just wait a second. Right up here.
Thank you, Gina. Miem Yang Nguyen from University of Maryland. I would argue that as long as we focus only on malaria, I think that we will fail to eradicate malaria in the long run. As long as we cannot integrate whatever we are doing in eradication into other diseases, other conditions, as long as we cannot diagnose malaria with other diseases, they are more common in some setting than malaria, as long as we cannot integrate treating IPTP for pregnant women into maternal child services, I think that we will not eradicate malaria. And I think that that's an innovation. I mean, I would like to hear from the panel what kind of innovation that we are supposed to be doing or we should be doing in the future.
Great. Can I have one more question from anybody? Yes, back there to our right. Thank you. And then we'll ask the panel to address these.
Thank you. My name is Winter Koth, and I'm a graduate student from Johns Hopkins School of Public Health in the laboratory of David Sullivan. And I agree with most of the sentiments that have been shared. But one of the things that I think that needs to be paid attention to is capacity building. So when you really do thorough training of the young scientists in these malaria endemic countries, that will help a lot with all the interventions that we've talked about here and also the new innovations that we're thinking about. How can we sustain the programs back there? I'm from Kenya, and I know how it is. And for everything that we've talked about here, the political aspect, the socio-economical aspects, what can we do so that we have more young scientists like myself, to be back home there so that we can help sustain the programs and also engage and feel like we're involved, in the fight against malaria to help eradicate it. Thank you.
Thank you. So we had three big questions there. One was cross-sector, and actually some of that will be tackled in the next panel, but we should talk about it in terms of its impact on innovation. The second is capacity building and country engagement. I think there's some good thinking here. And then this issue of, is it malaria? Is it vectors? Is it the mosquito? How do we leverage the attention on things that aren't malaria but could be of relevance? So let me just go down the list. You can start here.
Okay. Well, issues of capacity development and integration and country or program ownership of the problem are really what CDC emphasizes in all of our global work. Malaria will become more, as it becomes a rarer, as we're successful and it becomes less and less common, the incentive to implement a test that looks only for malaria or provide a treatment that deals only with malaria will become less and less. And so it is key to being able to link up with the ability to detect, diagnose, and respond to other causes of disease. I think surveillance is another key thing. It's a little I. It's not the kind of breakthrough that maybe we're hoping for, but it's being transformed already. When we started out,
to quote Dr. Alonso, surveillance is our vaccine until Dr. Hoffman comes up with something better. He really believes in the power of it. So it might be little I, but it could have a huge impact.
But when we set out at the start of PMI or at the start of the Global Fund, countries were collecting malaria data. It wasn't helpful to us. We knew that everywhere needed mosquito nets. We knew that ACTs were barely being reached, and there was no diagnostic testing for malaria. By rolling out diagnostic tests, we've actually quietly changed that paradigm. More than half of the cases reported in the World Malaria Report from Africa are diagnostically confirmed now. If we could just track that, that would be enough to know what the trend is. And more importantly, or to the point that Mint made, that unmasks that whole set of non-malaria diseases that we can't see right now because they blend into a very heavy background of febrile illness that we presume is malaria.
Lee?
So I think that, first of all, with respect to vectors, I think that there is, I think that the role of vectors in general has been underappreciated, and one of the big advantages and one of the discussion points that came up recently was the fact that a number of these vector interventions actually do apply across multiple diseases. And so if we're thinking about ways that we want to intervene against a number of arboviruses, for example, isn't there overlap between that and what we're doing in malaria and filariasis and West Nile and so on? And so that is a discussion that is going on very actively now. I think that one of the issues with vector control has been the fact that many of the vector control interventions were basically developed in the context of the agrochemical industry. And in the discussions that have been going on, it's been pretty clear that they don't have the same perspective on public health measures as public health agencies do. And so trying to initiate that dialogue and understand what's required is starting. There's been a lot of progress in the last year or so. And we actually did a very interesting exercise and put together one of our first product development plans for a mosquito-based or mosquito-targeted intervention for public health, where we look specifically at a public health impact of an intervention. I think with respect to capacity building in developing countries and country engagement, that's absolutely critical, and obviously it's essential for the sustainability of any sort of program. And we are talking here about a long-term sustainable effort. So we build that into our research efforts, and we hope that people take advantage of it. We try to encourage them to, and we will continue to do that. And then I'm not sure that I understood what Yang's question was exactly.
That's all right, you don't need to answer all of them. Let's keep on going. Steve.
Okay, so I'd like to start with the graduate student from Kenya. I think that many of us, and many in this room, have been engaged in our entire careers with trying to enhance capacity in the countries that where we work, because at the end of the day, that's the only way you're going to succeed. But I'd like to tell you guys about an interesting development program that I'm most proud of. Before I get to that, I'll just say that in Western Kenya, where we're working, we've hired 4 Kenyan physicians who are being trained in clinical research. There's a staff of about 40 individuals only working on this project, and they're being trained by one of the premier data management groups of the United States, and they're interacting with them every day. So we're training data managers to people who are social anthropologists going out to the community, to physicians. But one of the most exciting for me has been a project which began in Tanzania and now is going back and forth between Equatorial Guinea and Tanzania. So in 2012, we did the first clinical trials in Africa of our PF, Plasmodium falciparum sporozoite-based products, and the first controlled human malaria infection in history in Africa. And it was done at the Ifakara Health Institute in Bagamoyo, Tanzania. And we opened this new facility for clinical research so that Africans could actually be participating not in phase 3 clinical trials or late phase 2, but actually could be participating at phase 1 with all that that has to do in terms of capacity building, research, and so on. And we've done multiple clinical trials there. But then several years later, we were approached about the potential of working in Equatorial Guinea. And 2 things occurred at that point. One, some of our colleagues said, how can you work in a country that has a dictatorship and so on? And so we put together an advisory panel of our African colleagues, scientists. It was Dr. Fred Binka from Ghana, Dr. Ogabera Duombo from Mali, and Dr. Salim Abdullah from Tanzania, along with a series of European counterparts and counterparts here, with Chris being one of those, and Larry being involved all the way along. And they all said, look, if we don't work there, we might as well not work anyplace. So we started to do that, and we were faced with the challenge of starting in a country where there had never been a clinical trial done. There was no national or local IRB, ethical review committee. There was no regulatory group to actually import an investigational product, and there was no physician scientist or any other investigators. And with the support of the government of Equatorial Guinea, which is 75% of it, 3 US oil companies led by Marathon Oil and Noble Energy, with the support of something called Medical Care Development International, which is the project director is sitting there, Julie Carvalho. And we actually engaged with the Ifakara Health Institute in Tanzania to become, I think, the first CRO in the history of Africa. That's an African CRO to move en masse people to Equatorial Guinea to train the Equatorial Guineans in place to actually do all of this, and then send them, the Equatorial Guineans, to Tanzania for further training. And we've now finished, and with help of WHO Afro, we have an ethical review committee, a regulatory department. We've finished 1 clinical trial and are on our way to finishing the 2nd. And more importantly, in the whole history of malaria vaccine development, there's never been a clinical trial, as far as I know, in older adults over the age of 50, because nobody thought that they were important, but they do transmit malaria. So in Equatorial Guinea, they've done the first trial in history of older adults. They've done the first comparison head-to-head of 2 of our vaccine products. And this, so that capacity building is at the heart of everything we're doing. We're sending individuals, physicians, out for PhDs. We're sending undergraduates out for masters. And this is all in the context of an overall vaccine development program called the Equatorial Guinea Malaria Vaccine Initiative, which involves partners that are all over Africa, Swiss Tropical Public Health, the University of Tübingen, and groups in the United States from the University of Maryland, CDC. So we're very mindful of all of that. And so thank you for raising the question. I'd just like to respond to Myung, all right? you know, we've had this thing, you know, vertical, horizontal, you know, and at the end of the day, how do you do it? But I would just remind you that we haven't eradicated syphilis in the United States. And it's, you know, there was just an outbreak of syphilis. We haven't eradicated gonorrhea. So we're not doing that well in terms of eradicating any infectious diseases. And malaria in certain places, like Sri Lanka, where they did do a concerted effort, but they have fantastic healthcare delivery system in that country with very good life expectancy and so on. They did use the local healthcare delivery system to identify the last cases. But I'm not sure that in places like, you know, Western Kenya or areas of Mali that you're going to be able to do this at the stage we're at now without a vertical malaria dedicated program. It remains to be seen when we get to the end of the day. So I think my answer to you would be that it's really going to be varied depending upon the epidemiology, transmission dynamics in any one particular country.
And at what phase? Larry?
Yeah.
Well, just at the risk of ever disagreeing with Steve, I would say there probably are opportunities that we haven't taken very good advantage of them, particularly in Western Kenya, which we all know pretty well, in terms of surveillance, tying together a lot of these efforts. We're not going to eliminate in Western Kenya without good surveillance either, and that's going to have to be surveillance that's not just focused only on malaria, at least at the end of the effort. So I think there are. I don't think we've done. I think that we could do better, and I think when I was at CDC and Patrick's job, I didn't do a very good job about thinking about ways to integrate some malaria activities. Not wholly, because there are some things that, you know, probably stand better, more focused, but there are opportunities, measurement opportunities, survey opportunities, community engagement opportunities, and surveillance opportunities that we haven't taken advantage of. I just came from the NTD summit in Geneva, and they're all talking to each other about how they can integrate. Now, there are a lot of similarities in some of those programs about the preventive chemotherapy approach and so forth. But they're thinking hard about how they can integrate with each other because there's even less money in NTDs, and so they have to. I didn't hear malaria mentioned very often in the context of those discussions, so there probably are some more thinking and discussing that could be done in that vein as well. Anyway, I'll stop there.
Well, thank you. We've covered a lot of ground, starting and launching from innovation, but running into the realities of scale, integration, cross-sectoral. The last question is actually financing. And there is no question, whether you look at the World Malaria Report or I2I or any of these, that anywhere you look at in malaria, we need more money. So I'm not going to ask you, do we need more money? Because I think I know what your answer will be. My question is, how can we do it smarter? Are there places that we need to be thinking, and perhaps it's integration or leveraging, et cetera, about doing what needs to be done in a way that leverages what other parts of the field or other fields are doing, so that what we're doing is more efficient or done in a better way? Do any of you have any suggestions about how to think innovatively about how we could need less?
So I think it was brought up earlier by Chris, and it's been brought up. I mean, the whole process is going to fail at the end of the day unless there are funds from the countries that are most affected. And it's not as if there isn't money in a lot of these places, some of it better spent or misspent. So I think that at the highest levels in the countries in which we work, providing ownership, providing some idea that you're actually going to be doing good. So I'm going to go back to Equatorial Guinea again, you know, and again, it's a unique situation. It's quite a, from a GDP point of view, a wealthy country. But when I went to see the Minister of Mines and Energy, who was in charge of all the oil, you know, the first thing he said to me is, says, I'm under no delusion about how we're perceived in this world, and we want this project to show that we can be a beacon of progress for the world also. And so that's what we've worked hard to try to promote. And I've been met with some other African leaders and so on, trying to sell that story, which is that's not a story, it's the truth. And it's good for their people, and it's good for development. So the question is, how do you shift it so that leaders get invested in the idea that they can get something good out of this, even personally and as a leader, that will allow them to do good for not only for their country, but I suppose for themselves, like all of us. And we all do this for a variety of reasons, and you can't, there's personal aggrandizement also in the process. So I think that's a resource, and in a lot of these countries, there's a lot of wealth, and that hasn't been tapped.
What I've been told, and I don't know that I have a data point for this, is that the #1 funder of what it takes to control malaria in countries are the countries themselves. They are already the #1 funder. And what these global funds are doing is helping provide, sorry? They are, okay, yes, I just don't know the data point. That they're helping provide the commodities, which require external exchange of currencies, et cetera. So we already have countries as the #1 funder, but we also already have a huge gap. And I'm mindful of that. I don't think we're going to resolve that. But it's probably going to be resources from every place, but also challenging ourselves to think about how to do it faster. The longer it takes, it's like a clinical trial, the longer it takes, the more expensive it will be. So whether it is using MDA or other ways of approaching residual transmission, or thinking about how the package of all these individually developed, innovative solutions work together, we have to learn how to do it faster so that it is faster. That's what will end up costing less.
And that's information systems again. If you had nimble enough information systems that would allow you to shift your resources, or better yet, tell you when there's a reversal or an unexpected change in time to reorient yourself.
And actually some of those things exist and are being tested already.
That's right.
All right, let me put a stop to this. Thank you very much, panel, for taking our questions and for engaging, and all of you for listening. And we will now hand the podium over to the next panel. Thank you very much.
Hello. Trying to get coffee. I know. We're going to get started right away with the next panel. We're going to flow right in, and hopefully people will just quickly get some coffee and come back. But thank you all. It's been a great day of discussion and presentation so far. My name is Audrey Jackson, and I'm a senior fellow here at the CSIS Global Health Policy Center. I lead our policy work on malaria, among other things. Our third and final panel today is going to delve into a subject that was touched upon earlier, the critical importance of partnerships in helping to advance the malaria eradication agenda. So my colleagues and I in the Global Health Policy Center over the years, we've traveled to several countries to examine US-funded malaria programs and how those programs engage with ministries of health, NGOs, and other international donors to support and implement malaria elimination activities in those affected countries. Just last month, I published a report on malaria in Nigeria, and those reports were available downstairs, so hopefully some of you picked one of those up. Nigeria has the world's highest burden of malaria cases and deaths, and it very easily represents the challenges that are faced by many high-burden countries, in particular as they try to get a handle on malaria control and start to maybe even think about malaria elimination. In Nigeria, with the support of PMI and other international donors, they've been able to drive down malaria prevalence in the last 5 years from 42% to 27% from 2010 to 2015. And just to note that PMI actually only expanded to work in Nigeria in 2011. So there's been good progress seen there, but now as they start to set their sights on elimination, they're beginning to think about how to mobilize new resources, identify new sources of financing in order to be able to really expand access to different malaria control interventions. But they've committed to working towards elimination in 2030. So it's a good example. But in all the countries that we've been to, the ones that we've seen the greatest success is where partnership and coordination of efforts are really helping drive towards the goal. As we've said before, no one sector can really do it alone. And so joining us today are some great speakers who have a lot of experience working in partnerships in malaria. And they're going to tell us about some of their work. They represent a range of sectors, including the private sector, faith-based organizations, and academic sector. So they're going to tell us about the work of their organization, as well as their work with partners, and hopefully some of the challenges and lessons learned that they've encountered in their work. Dr. Dina Buford is the Global Medical Director of the Medicine and Occupational Health Department for ExxonMobil Corporation. Mr. Sean Callahan is President and CEO of Catholic Relief Services. Ms. Margaret Riley McDonnell is the Director of the UN Foundation's Nothing But Nets campaign. And Dr. Myung Newt is an Assistant Professor of Medicine and Director of IGH Myanmar in the Division of Malaria Research at the Institute for Global Health at the University of Maryland School of Medicine. And we'll start with Dr. Buford.
All right, Audrey, thank you. And thank you for inviting ExxonMobil to participate on this panel. We are so honored to be among the many dedicated soldiers in the continuing fight against malaria. While I'm sitting here, many of our ExxonMobil operating sites around the world are preparing or in the midst of observing World Malaria Day. And I think every year it's a moment for governments, civil society organizations, and even the private sector partners to reflect on the progress made against malaria. And also an opportunity to look ahead to the emerging challenges, many of which we've discussed today, that we must resolve. The recent progress against malaria has been nothing short of remarkable. I think we heard earlier today how malaria is one of the oldest diseases known to man. It's been around thousands of years. That's how it was taught to me in medical school, and I think the implication there, and it will be around thousands of more years. They didn't exactly say that, but it was implied. And yet, look where we are. We know that the progress is the result of incredible hard work of countless stakeholders to strengthen prevention, diagnosis, and treatment of this disease. Sometimes it really does take a village. ExxonMobil is very proud to have played a role in turning the tide against malaria, in particular through partnerships with organizations that have been instrumental in driving these scientific breakthroughs, improving delivery of health services. I think we talked a bit about capacity building earlier, where malaria and other diseases remain a threat. Just a bit, since 2000, ExxonMobil supported programs have distributed more than 40 million bed nets, nearly 3 million diagnostic tests, and more than 4 million anti-malarial treatments, which have reached more than 125 million people worldwide. We've also supported the training of 590,000 healthcare workers to ensure that these life-saving interventions are used appropriately. I'm often asked, though, why does ExxonMobil engage in the fight against malaria? Well, engaging in the battle against malaria is simply the right thing to do as a good corporate citizen in countries where malaria is endemic. There's just no more important point than that. But I would be remiss if I didn't point out the serious effect that malaria has had and could have again on our business. A little history is probably would be helpful here. Our large-scale involvement in the malaria field dates back to the construction of our Chad-Cameroon oil pipeline in approximately the year 2000, where we experienced the burden of malaria firsthand through our employees, their families, and the surrounding communities. Early on, we noticed that we had more employees missing work due to malaria than to any other health and safety threat. We knew that if our employees weren't healthy, our business would not be healthy either. So we initiated a corporate-wide malaria control program and offered free malaria services alongside other health care at our project clinics. To date, our workplace malaria control program has made significant progress globally. We have averted 2,000 cases of malaria since that date in the year 2000. And important for me, no employee or contractor has died of malaria-related causes since 2007. Now, although we're proud of what we have accomplished with our internal malaria control program, we knew that our employees would not truly be protected from malaria if it remained a major threat in the surrounding communities. ExxonMobil employees, and often their dependents, are members of these communities in which they work and are exposed, when they go home, to the same risks as their neighbors. So building on the success of our global workplace program, we began to extend malaria prevention and treatment services beyond our employees. ExxonMobil now collaborates with partners to expand malaria control initiatives around the world. Oh, wow. Part of this responsibility is to help fill gaps in primary health care. Through our community health programs, ExxonMobil works with local partners to shore up awareness of health risks and improve access to preventive treatment and other tools. To be good corporate citizens, we also recognize the need to scale up our efforts. You can't really play small ball with malaria if you want to make a dent in this. And that's where our ExxonMobil Foundation comes in. ExxonMobil invests in a range of programs that address critical challenges in the fight against malaria, including many of the things that we've discussed today. Development of vaccines and new drugs. Research to look into anti-malarial drug and pesticide resistance. Data collection and surveillance. Delivery of life-saving control interventions like bed nets, rapid diagnostic tests, and anti-malarial drugs. And health system strengthening, capacity building, and leadership training. I'll also ask about the nature of our support. And our support is not just financial. We continue to work very closely with all of our partners, using our business expertise to identify best practices and to advance additional public-private partnerships. We've helped various stakeholders collaborate effectively while we're doing all we can to protect our people. For example, in Angola, ExxonMobil participates in a forum to align our public health initiatives with national guidelines. We seek guidance from the National Malaria Control Program. And this close coordination and relationship building that we do there is essential, we think is essential for determining the best response when outbreaks arise, such as the recent yellow fever outbreak in Angola. We've even worked with the French Army to develop a new chemoprophylaxis compliance test, which is designed to be used in the field and provides quick answers in approximately 10 minutes. And we collaborate with the CDC on other emerging threats and in the area of global health security. But in addition to partnering with governments and NGOs, we also work to share best practices with other private companies who face similar health challenges. Like the organizations like the Corporate Alliance on Malaria in Africa and CSIS's Commission on Smart Global Health Policy and the Global Health Security Agenda, all of which enable companies from diverse industries to share lessons and best practices on their own workplace programs. Lastly, we help convene national and global policymakers and program managers to discuss emerging trends. An example of this support would be our participation in the Science of Eradication Leadership course run by Harvard, the Swiss Tropical Institute, and the University of Barcelona. This course brings together leaders from international health agencies, ministry officials, and on-the-ground practitioners, including some of our own ExxonMobil Medical Department providers. On this World Malaria Day, ExxonMobil continues to be a corporate leader in the fight to reduce the global burden of malaria and other infectious diseases. We believe that these investments are our responsibility as good citizens and are in our interest as a business with a global footprint. Thank you.
Thank you so much, Dina. And now we're going to hear from Sean.
Thank you, Audrey. I'd like to thank CSIS and ASTMH for inviting us here today. To me, this is a great event because it's a bold event, and I think when we're addressing issues like this, we need to be a little bit bold. And if those of us in this room are not the ones to be bold, then who will take that step to move this forward? At Catholic Relief Services, we work in over 100 countries around the world, reaching over 100 million people every year, 47 million of whom are directly related to malaria, and we distributed over 22 million malaria nets around the world. But let me tell you 3 different challenges that we have faced. One challenge is when we started doing this type of work about 10, 12 years ago, one of our board members kept questioning, why are you going to distribute these nets out in these various countries? You know they're just going to become fishing nets for people. No one's going to use them. They'll go out there and you'll collect a lot of fish in Nigeria and other places, but you won't resolve the problem. So that's one challenge that we had. Another challenge that we had is just recently I was in an African country and I was sitting next to the Deputy Prime Minister at a nice event talking about malaria. And he commented to me rather nonchalantly, because he has a nice house along the lake, that he gets malaria probably 4 times a year. Just a natural course, something that happens, not something that we prevent. But here's a leader of the country saying, this is normal business here in this particular country. Or even more extreme cases, when I get a call, urgent call from one of my country representatives in a country saying, I just got a call from the president, and the president is pretty upset. We received funding for malaria, and he kind of accepted that we would help build up the ministry in its response to malaria. But now we were getting funding also for Ebola, and it wasn't going to the government. And he had an election coming up in a few months, and he needed the funds. So you can imagine why the money wasn't going, to that particular government, because of the challenge of governance and how these funds were going to be used. We talked about innovation and other aspects. I'd like to raise 4 other areas that I think are crucial to us eradicating malaria. And those would be trust, success, urgency, and a human face. And when I look at the ways that we intervene in these areas, one of the key ones in the local communities is behavior change. And you can't implement a program or try to produce behavior change if you don't have the trust of the local community. We found this in our HIV/AIDS programs, and we found this in many other areas. And I think we have to just look at it as a way of how do we get into the local communities and make sure that the message we're providing is being provided by the right message carriers. And so that key trust, those who are with the communities during their most difficult times when their father died, or a woman was having a difficult pregnancy, or their kid was severely malnourished, it's those times that you have to be there if you're going to implement these behavior change. In addition to that, we talked a little bit about capacity strengthening, crucial and key area. As we look at the capacity strengthening, it's at all different levels. We need to do it at the community level, we need to do it at the regional level, we need to do it at the governmental level, and we need to make sure that we're combining and integrating these different efforts in the various levels and by the various partners. It is really crucial that the systems are also in place. And as we look at our HIV/AIDS response and we look at our malaria response, we're finding that each of these responses is helping with that next disease or next pandemic that comes along. The systems that we had in place for malaria and HIV/AIDS helped us amazingly in Liberia, Sierra Leone, and Guinea in responding to the Ebola crisis. The trust was also crucial because many of the governments didn't have that trust of the local community. You can imagine if you detect Ebola in a certain area of a community and you wall off that community with a military cordon, how many of the people in that community are going to think the government has their best interests at heart? Not very many. But if the local community and local organizations are there providing assistance to that community during that difficult time, then we have the possibility. So health system strengthening, crucial to these partnerships, as well as a public-private network. In some cases, some of our partners work closely with the governments. In some areas, they're replacing the government. We need to make sure that when they are substituting for the government in areas, that there is a plan for building the government back into those areas and a transition of those services. Integrated programming is also absolutely essential. We don't do malaria as a standalone, but as part of safe motherhood and child survival, as part of a program of income and microfinance as part of our agriculture and watershed management, because they're all interrelated. If they're not taking care of their water resources in those different areas, if they're not applying proper hygiene techniques, then we can keep putting them under mosquito nets. We can have the children taking seasonal malaria chemoprevention and things, but it's still not going to result in the results that we want to have. So we need to integrate all of our programming and do it in what we call integral human development, making sure that all those aspects are being bonded together. I mentioned trust. Success is also crucial. We need to make sure that we get the data in this so that we can show and prove to people that it is success. Not only is that important for the funders, but it's important for the people who are implementing the programs. If we're asking people with meager resources to do extra work in cleaning their community, to invest their resources in a certain way, we have to be darn well sure that those investments are changing their lives for the better. And so we have to have that data and show them that their lives are in fact changing. And I think it's wonderful that we can do it at the micro level, but I think the numbers that we saw earlier here today were crucial in seeing how we address the malaria issue in a more global scale, and I think that can help push more and more. Success is also key because people want to be on the winning team. They all like to hear about the success of these things, and so if we can help governments see how the success is moving forward, if we can, instead of criticizing, laud the governments for that and use a little bit of positive inquiry to help move them forward, I think we can again have other successes. Lastly, I would say it's the human face. Today we did talk a lot about innovations and numbers, and that's wonderful. But when you think of different tragedies that we've had around the world, particularly the migrant crisis is one that comes to mind. When you think of the young boy, Alan Kutri, who washed up on the shore in Europe, it really struck a note when we see the death of a young child trying to move for a better life. This is happening every day in the countries in which we serve due to malaria. Every single day, young people are dying because of it, and there's no picture of someone on the beach. There's no picture in the newspaper. Nobody hears about it. We have to do a better job of letting people know that these are our brothers and sisters that are suffering.
Thank you so much, John. In the same vein, we're going to turn next to hear from Margaret about Nothing But Nets.
Hi, everyone. So I think I'd like to take everyone back to 10 years ago. It's kind of a fun story, silly story, but hopefully it's inspiring. I know it's been a long day. So about 10.5 years ago or so, Rick Riley, who was a journalist at the Sports Illustrated, I think he was in Italy shopping with his wife and was bored of shopping, so he decided to retire to his hotel room, turn on the TV, and saw a BBC special about malaria. And at the time, a child was dying every 30 seconds from this disease. And he was shocked. He had never heard, he had no idea the impact that it had. So long story short, he came home. He ended up writing an article. He had the back page of Sports Illustrated at the time, wrote an article calling his fans, saying, hey, I don't want to talk to you about hoop nets, soccer nets, lacrosse nets. Today I want to talk to you about the power of life-saving bed nets, mosquito nets. And within, I think it was a week or two, he had raised $1 million from sports fans. And these are people who, are not your development wonks. No offense, not people who attend events at CSIS, even though they're wonderful and we're all fabulous. But these were people who had never heard of malaria probably before because they'd never had to encounter it in their daily lives. And so he actually, the story goes, he literally picked up the phone. He knew the UN worked on malaria, called Kathy Calvin, our president and CEO, and said, hey, can you set up a web page? I'm about to come out with this article. Get it up. And long story short, that's what happened. Within a week or two, $1 million had been raised. So that was 10 plus years ago. And of course, the reason it struck a chord with everyday people was the tangibility. The shock of every 30 seconds a child dying, and the tangibility of they can actually do something. And at that time, as we know, BedNet was costing around $10 from procurement to shipping and distribution. So that felt like something, you can actually do something. Everyday Joe on the street can make a difference. So the campaign got launched from there. Because of that, the way that it started, we were able to develop really unique partnerships. So sports partners. So we're partners with NBA, MLS, now Athletes for Hope, Whistle Sports, which is sort of the next generation of how young people consume sports. And of course, we have champions like Stephen Curry, NBA MVP. We're lucky to have him. He donates 3 bed nets for every 3-point shot he makes during the season. And he happens, I joke with him that it's because of us that he's such a good 3-point shot, because it was literally the season we got him on board for the 3-for-3 challenge. He broke the NBA record for the first time and has gone on since then to beat the NBA record. So I think it's because of everyone in this room that have helped to inspire him. But truly, he traveled with us to Nyarugusu refugee camp in Tanzania 4 summers ago, and says that he thinks about the kids, the kids and families that he met with. He thinks about them when he's shooting. Not maybe every time, but he's inspired by that. So along with sports, faith-based partners, so similar to CRS, United Methodist Church, Lutheran World Relief, they were all inspired by, obviously for faith and spiritual reasons that wasn't moral, wasn't just, that kids were dying. And as many have quoted, too much is given, much is expected, this feeling of service. As well as the Union for Reform Judaism, or the Religious Action Center for Reform Judaism, has also been a really important partner of ours. The private sector, of course, has been critical. Exxon and Chevron have done amazing work. We were able to strike a partnership with Orkin, so we also have new partnerships with some of more vector management. So cause marketing partnerships that allow, for every spraying of someone's home, they're providing a bed net, or these sort of, and it benefits their bottom line because they're activating their employees around this issue. And we know about the millennials that impact matters, and even more so today than ever. Young people care about making a difference in their professional and personal lives. So say what you will about millennials, but people want this. The world is smaller, and they know that, and they want to make a difference. And so, finding ways to leverage that for corporate branding. So we've been able to do that. We also have partnerships within the bedding industry, talking about a safe night's sleep. The importance of a safe night's sleep. And so we have partnerships with a company like Parachute. They provide, beautiful, very expensive but lovely bedding, and for every particular set, they donate bed nets. So we've been able to leverage some of that. Youth, I think this is one of the most unique components of our campaign. Because of the tangibility and perhaps at times oversimplicity of the issue, we've been able to recruit thousands, tens of thousands of young people to care about this issue. Because again, they've probably never heard of it. It's almost like my generation with polio. I hardly know anyone who experienced it firsthand. These kids certainly have not, since it was eliminated in the US in 1951. But why do they care? They care because they know what it's like to get a mosquito bite. But the worst case for them is it's itchy. They cannot fathom the idea that children still die from mosquito bites. So it really resonates with them. And not only do they know the problem, they know, one of the solutions and how they can make a difference. So we've had incredible young people. Nate Stafford, a Boy Scout who hiked 100 miles to raise funds for malaria. Catherine Kamali, who through big sales and creating gift cards, raised over $200,000. I mean, it's really incredible. I just came from our annual leadership summit is happening a few blocks away at the Kaiser Family Foundation, and we have around 125 or so of our best champions from around the United States. I think there's about 20 or 30 of them who are under 21, and you should see these kids. I mean, it's amazing. They're just so articulate and so passionate, and they care so deeply about this issue. And of course, civil society partnerships. We've worked really closely with Junior Chamber International, which is like a Rotary of sorts. It's comprised of hundreds of thousands of young global active citizens around the world who care about this. They've led a buzz tour, they call it, across the United States for 3 years in a row. They've done more than 300 meetings with their members of Congress in district and on Capitol Hill. And again, because it's something they can do. It's something where they feel like they can make a difference. So, we're really proud of, we're not the technical partner. We work with technical partners to help advise us on best investments and strategies, but we help to really bring this sort of strange bedfellows, if you will, this cross-sectoral partnerships and public engagement piece, which is really, I think, important, especially in light of where we are today with budgetary and political climate. So I'd say some of the key ingredients that we found, one of our cute little catchphrases. You know, we say we engage from bishops to basketball players, from corporations to constituents. You know, sort of one of our cheeky little marketing ploys. But in terms of some of the key ingredients for partnerships, you know, we talk about they really have to be mutually beneficial. We've had some partnerships that just we weren't feeling it anymore. It just wasn't working, right? So it's always important to sort of reassess where you are with the partnership and if it's still working and if there's still value being brought to both sides of the table. Certainly the complementary, you know, so we know we're not the technical partners, but we work closely with others and we help to bring other ingredients like Americans who care about this issue, you know, constituents that can tell their member of Congress, no, you know, I've got your back, this is important to us. The impact, I mean, so you talked about some of the key ingredients, the ability to show progress, I mean, that is what, it was the devastation of the every 30 seconds that got people hooked, but what's kept them along is the progress that's been made and the milestones and the goals that we're all working towards. So when we talk about 6.8 million lives have been saved, or 71% of kids under 5, you know, the reduction in mortality. This is what keeps people in the fight. And we talk about, you know, 2040 or, you know, 2030 to 2040, whatever we want to call it, it's a goal, and talking about how we can be the generation to end malaria. That's really powerful. So we're excited about that role that we play. I'd say just to, because I know we get, you know, bad rap, nothing but nets, don't they know, you got to do more than nets. Well, I'm here to tell you, we actually do more than nets. We've talked about, you know, crossing out nothing but and putting more than nets, or nothing but nets plus, or beyond nets, or whatever it is. That the reality is that our brand is quite good, and it's hard to completely evolve from that. So what we're doing is sort of evolving our messaging and branding around that. We're talking about our pledge to protect. We have a cute acrostic that talks about what all of that means, but it includes, we actually provide more than nets. We do diagnostics and treatment, innovative solutions. We're actually going to attempt some pilot studies with PVO and second generation nets. We fund community health workers, our advocacy work. So we do a lot more than nets, despite our name. And where we've really focused, which is, again, it gets to the complementarity piece, is that we're strong advocates, of course, for the President's Malaria Initiative and the Global Fund and UN, and also working in close partnership with PAHO and the Americas piece. We've seen that, you know, the refugees, sort of where we do our fundraising and our grant making work, is really to help protect some of the most vulnerable populations, refugees, IDPs, because we found that they're not as prioritized as much, especially by host countries. So that's where we've really focused our energy in terms of our direct service work. Of course, our advocacy work is more in support of, you know, PMI and Global Fund in the UN. So again, we sort of touch on the fundraising, granting, bringing champions to the table, and then our advocacy work, which is, of course, where we have the greatest impact. Because we know we've raised $60 million, we provided over 10 million bed nets. We're impressed by that, but we know we're relatively small players in terms of, you know, that work. And really where we can have greatest impact is on the advocacy front. And so, and to your point about storytelling, we're actually really excited. We just recently launched a virtual reality film. Who here has watched VR? 1, 2, 3, okay, a few more. Okay, well, so we created this amazing virtual reality film. So if you haven't done VR before, it's fully immersive. We say it's the second best thing from actually going to, you know, a malaria endemic place. It's called Under the Net. It features the story of an 11-year-old girl named Amisa. She's amazing. Her and her mother and 6 siblings who have had to flee into Nyarugusu refugee camp in Tanzania. And this tells the story of life as a refugee, and their hopes and dreams and the challenges that they face, including malaria. And of course, their family receives the net at the end. But in the meantime, 2 of her siblings contracted malaria. This was not posed. This was literally the week we were there to film. That was just the reality, because 65% of refugees in Africa and Asia are subject to malaria. So we hope that this is a really powerful tool. We've won some awards. We're at the Hollywood Film Festival. We're going to be taking it to Iowa, you know, from both coasts and everywhere in between. And we're actually going to be taking it to Capitol Hill tomorrow as part of our advocacy meetings. And we hope that it can be a tool for the whole malaria community. It's really powerful. It does require headsets, so it's a little, you know, it's not as straightforward as, you can watch it on your computer, but it's a better experience when you're fully immersed. But it's that empathy building and that connecting and making it real for people that I think is really important. So the storytelling piece, I think, is key. So I'll stop, but I think just saying, of course, at the UN Foundation, we care about all of the Sustainable Development Goals and the UN, and we obviously are concerned, like everyone here, in terms of proposed cuts to both foreign assistance and the United Nations. I mean, they're talking about 40 to 50% cuts to the United Nations. Of course, the expansion of the Mexico City policy to all of global health funding, which is going to have serious implications. So, this is no greater, more important time than now to work in partnership, because that is the only way that this is going to get done. We know that we're going to have a hard enough time holding the line, frankly, and we know that to achieve the global technical strategy and the SDGs takes double the resources. And now we're in a situation in the United States anyway where we are going to be fighting for flat funding, and we hope it will be more. And of course we will be asking for more, but I think realistically it's really tough. So I hope that this hopefully will help to inspire even greater, more serious dedication to partnerships, because it's more essential than ever.
Mm-hmm. Thank you so much, Margaret. Yeah, it's great to continue telling the stories of partnerships and what we've been able to achieve, and hopefully we'll continue to build on them. So now we'll turn to Mian Yang, who will tell us a little bit of a different perspective from her work in academia and I think in Myanmar.
Thank you, Audrey. Thanks, Steve and Karen, for inviting me to be part of this panel. I think I'm just going to, I have a little list, but I think I'm just going to change my mind and tell you a little bit of my personal history, personal story as an academia, but also as somebody who has lived with malaria and who kind of went through this time of turmoil, political and social turmoil, as I could be called a refugee, or I could be called an illegal immigrant, or I could be called a student activist, whichever sounds good. So I'm a faculty member now at the University of Maryland. I grew up in a country called Burma, or Myanmar. Left in 1988, had never seen malaria, nor had no interest in malaria, because we didn't see malaria in a city I lived in Rangoon. So the first time I saw malaria was when I left and lived on Thai-Myanmar border. And that was the first time I saw in 1988, late 1980s. That was probably the darkest ages of malaria. Malaria was rampant, and there was no available effective drug. So that was a time that chloroquine was failing. So I was a medical student, and so I suddenly become a doctor. I wanted to be a fighter against a government, but never had a chance to do that, but I was faced with malaria. Thousands and thousands of students, young people, left the country because we were all angry at the government. Military dictatorship that many of you probably know. I hope that there are a few people in the audience that are still here who will go back to your congressman or the senator or appropriator and tell them and convey the message that I want to send. So that was a time that there's no drug, and many of us were non-immune, not even a semi-immune, because we had never seen malaria. So we fell ill left and right. And that was the time chloroquine was gone, and there's a drug called Fancida, which we consider as cheap, but we couldn't afford it. We couldn't afford Fancida. Mefloquine was nowhere to be seen, it's too expensive. So we kept pumping the drug into the patient, and the patient never got better. A lot of them died. And so we used, the only drug we had was quinine, or quinine. And I don't know if you have ever taken quinine. No, I'm not talking about gin and tonics. I'm talking about quinine. And I said to myself, I would rather die of malaria than take quinine again, ever. It's a horrible drug. It's a lot of side effects. Tolerability is very, very low. So that was my first experience with malaria. It was depressing. I had never heard of malaria research at that point. And so, it was a depressing time, and, I lived on the Thai-Myanmar border for a couple of years, and then after that I left. Spent a year or so in England, and eventually immigrated to the US, where I educated myself from undergrad, medical school, everything else, and until now. So that was my experience with malaria as a young activist. And then I went back in 1999 when I was last year of in medical school, and worked with the malaria research group. So it's a power of research that I see the first time in my life. That was malaria was under kind of control, and situation was much better. And used to be that malaria was basically a death sentence for pregnant women. The group that I was working with, they were testing malaria drug in pregnant women and trying to test on a regular basis and treating them every time they see malaria. So malaria was not a death sentence anymore at that point. And so that was the first time I saw the power of research. And it's really a saving lives. And, but I also see the lack of, I also see the impact of lack of partnership. So there was no real partnership between research and program and service providers and cross-border. There's no cross-border collaboration between Thailand and Myanmar because of the political situation. That was also a very hard time because the Myanmar or Burma was under the US government sanction. So those fundings were directed towards different groups who are working in different areas. So there's no real collaboration, there's no real partnership. So during that time, I want to tell you a couple of stories. One story is when I was one of the members of the mobile clinic on the Thai-Myanmar border. So we moved from one village to the other to test malaria and treat. So there was one young man came to us. The group that I'm working with is known for treating malaria for the refugees and illegal migrants and people like that. And so this young man came to us, and he looked different. We knew immediately he was Myanmar soldier from Myanmar military. So he crossed the border, crossed the Moi River, and came to us because he needed malaria drug. He was sick. He has a temperature of 104, shaking. And so we knew, just from his look, the crew cut and the way he dressed, and we knew he was a soldier. But we have to treat him. And we asked him, so did any of your friends or your villagers or other soldiers, are they sick? Yes, there are 6 of them. 6 were sick. So we gave him extra drugs and we sent them back. So that was the first time. So I was, since I left that area, I always said to myself that I will never go back to this country until the government change. No partnership. I do not want to work with these people. I do not want to shake hands with these people. I will go back and work only when the government change. So but that was the first time that I saw the person from other side, from dark side, suffering. So it's that people suffering are not just us, the people from the country, people on the border, people, the refugees and the illegal migrants, but there's the soldier. This is part of the government, and he took the risk of crossing the border. He knew that this area that we were working was controlled by the armed militia. He knew that if we were caught, he would be killed. But he crossed the border because they were all sick. So that was my one experience. Another experience I had was the same experience that when I was working there, we had a pregnant woman who came to us sick, and we tested malaria. She was negative. She was about 7 months pregnant, big. Malaria was negative, so we said, well, you know what? We don't really have drugs to treat your UTI. Urine was positive, and so we don't really have any drugs to treat UTI. We have only malaria drugs. So we sent her to the other clinic where she can get antibiotics or something. So she left. About 3 days later, she came back, still sicker. His blood pressure was low. So we tested again. This time, she's malaria positive. So we treat her immediately, but we knew that she was going to crash. We knew that it's going to is happening. We put her on the pickup truck with the IV bag hanging, squeezing the IV. Blood pressure was falling. So we had to cross the border. We go into Mesot. It's a small border town in Thailand. And we couldn't even go into the hospital because we're not working with the hospital. So we had to drop her there. And a couple of days later, we heard that we were informed that she died. So that was another experience. So, but anyway, so these experiences are the ones that who actually made me change my mind. I was so sure that I was going to go into emergency medicine. And I changed my mind and go into medicine and trained in malaria. So these are my two stories that stayed with me, how fragmented the work that we're doing. I also think that malaria really thrives in the fragmented societies. We know that many countries that we work in, there's a reason, right? There's a reason why these countries are in trouble. These countries still have a huge burden of malaria. The country is fragmented. I know, of course, close to my heart, in Myanmar, in this country, there's a government, non-government. There's a civilian and military. There's a good government and bad government, and think that these fragmentations are making things worse. And the way we work could fragment more sometimes, and so that's how I started thinking. I used to work in Mali. I used to work in Zambia. I used to work in Bangladesh. My life was more enjoyable then because we work with the research group. We do our research. We're very happy to have our little data set, and we are very proud and happy when we see our names on the publication, whatever journal that we publish. But when I went back to Myanmar, the way I see things is very different. I can't do it. I just couldn't do it. And so we started, so the way we work in Myanmar is we work with many different groups. We work with the government, we work with the military, we work with the non-governmental organizations working in the country. So we brought our work as this kind of a saying of malaria as a catalyst. And because when you talk about malaria, people are interested. So Chris already talked a little bit about our malaria elimination conference that we held here at the CSIS in August of 2015, where the first time that Myanmar military and Myanmar civilian government and opposition party and the ethnic militia groups, the first time ever they sat together and actually talked about the problem. And at the end of that 2 days meeting, I talked with the one leader, health leader of the ethnic militia called Karen group, and I asked him, his name is Eklu. I said, Eklu, so are you okay? Are you satisfied? He shook hand with me, tears in his eyes, and he said, I am very satisfied. I was kind of stricken by the seriousness of his response. And so I asked, because I wasn't too satisfied, because there's a consensus, but we don't really know what's going to happen next. So I asked him what made him feel that way. He said, this is the first time that people actually ask me questions. This is the first time that people actually sat me down at the table and talked together. So that alone made him feel differently. And so that was my experience, and I can keep going forever. So I'm going to stop here. And so that was my experience, and I hope that these ideas and these thoughts will linger and we'll be able to use this or whatever work that we're doing. Thank you.
Thank you. Thank you so much, Myung. That was a very, very powerful, I think, sort of story about the great needs that still exists in malaria, as well as the importance of kind of connecting and working together and building these partnerships to both address malaria, but really start to build a society in the case of Myanmar. So thank you so much. Thank you to all our panelists really for some great examples. So I'll just start off with one question and then we'll open it up to the audience. Some of you talked about some of the challenges that you have run into. How do you overcome some of the challenges of bringing together groups that may have very different perspectives or different working styles or cultures or motivations? How do you balance sort of, you know, who takes the lead, the individual goals and plans of the donor, but also balancing it with what the country's needs are? Would anyone like to?
I'll take a stab at that. I think that there really does have to be some structure to the partnership. Although it may be driven by passion and the true desire to fight malaria, I do think that the partners have to agree for sure on a common goal. And I know that sounds obvious, but as we've been talking here today, there may be several sub-goals. So I think a good dialogue and coming to a decision on that, the priorities, obviously funding, but there may be some non-financial contributions that partners can bring to the table. Such as, you know, in the case of ExxonMobil, it might be our skill at project management or data analysis, et cetera. So I think failure to do that, which it can be so easy in the early stages of the partnership to kind of push that aside because it takes valuable time and we've got to jump right into the task at hand. I think that can lead to confusion and at worst, missed deliverables. So just bringing structure to that.
Great, thank you. Any other thoughts?
We often take the long-term approach, and the idea is once you begin a project that we develop an exit strategy as we're beginning the project to try to pass it on to the local community as soon as possible. But understanding that it is a longer-term approach. I just came back from a country and I was telling one of the donors that, you know, we're working well together and trying to assist, but it's going to take probably 5 or 7 years for them to develop the systems in place to really reach out and convert their systems into one that would be very effective. And the donor turned to me and said, 7 years? We were thinking more like 15. You know, so I think people know this, but it's a combination of the technical, of the mobilization, but then also the stewardship of the resources. I think we do a disservice when we don't steward those resources appropriately from the beginning and try to pass it on too quickly. So I think you need to have a plan. You need to show that you're committed to not aggrandizing your particular organization, and then highlighting the achievements that the local communities and the local government have made along the way to help them in that pathway forward.
Thank you. Any other thoughts from the panelists?
I think that you know, I can give one quick example of what has been going on in Mali.
Okay.
So you know what U.S. NIH and other University of Maryland is one of them. The other university who have been working in Mali for many years with a very strong partnership with the research institutions and universities and the government. And so as some of you may know what's happening in Mali is that because of the political instability and violence, a lot of our U.S. collaborator cannot even go there. But Mali kept going. Our Malian colleagues are independent and they are continuing their research activities and their program activities with or without us, because they have developed these skills and capacity and intellectual capacity, the know-how capacity, and so they keep going. And so that's a one good example of that when you build a partnership, very strong partnership for a long term, that stays. Regardless of the political situation, regardless of the other problems that the countries may face.
Thank you.
I won't add too much, but just to say that at least with our partnerships, I mean, we always try to, like you said, the structure, the collaboration agreements, the clarity, right? Because just like in any relationship, whether it be with your spouse or your grandmother or your roommate, you may think you're on the same page. You may think that you have a similar understanding of what the objectives and the goals and the milestones are, but when you actually sit down and discuss it and bring all the stakeholders at the table, you realize that there are different priorities. And I think really understanding what their perspective is and what's in it for them and what they want to see come out of it is really important in terms of baking that into the partnership from the beginning. And having that transparency and doing the assessing, regular assessments to ensure that you're checking in and making sure you're hitting those targets along the way and recalibrating if things aren't working. And then I will say, I mean, like I mentioned before, the complementary nature, I think you have to know that there is benefit from both sides, because that's how you can have the longest term, most sustainable partnerships is if both parties feel like they're getting from it what they need. So an example would be, where because of our partnership with a Bennett manufacturer, we're able to offer lower costs to some of our UN partners on the ground. And in return, I mean, we do ask certain things. If we're providing this sort of grant, we need X, Y, and Z, not only just the M&E and all the reporting, but we need stories, because we need stories of real people with real names, with ages, of course, protecting their privacy, but that will help us. Without that, it is very difficult to fundraise and to raise funds to ensure that we can continue funding you at this level. So I think that kind of, understanding at the get-go of what will help to make it effective. And our advocacy work, obviously working closely with PMI and the Global Fund on the stories. We need if we're going to be the most effective advocates that we want to be on Capitol Hill, we can't do that alone. We have to be fueled by information and data and stories and all of that from those partners so that we can be the best advocates that we need to be. So,
thank you. We'll open it up to questions from the audience. As we've done in the past, we'll take a couple, and there are microphones. Marcus?
Yeah, I just want to raise, I think Mia, that's your name, no? Yeah. I think Mia raised a very good point on the issue of integration versus non-integration. And to me, because last week I was in Geneva attending the NTD summit where Bill Gates committed $300 million for NTDs. The UK government committed £200 million. This morning I was in a SICA thing. It's too competitive. The malaria community, that is a risk. There is the SDG, it's an opportunity, but it's also a risk. The malaria community needs to be ahead of the curve and make sure that best practices are always there to show those who have the money that the value for money is there. Because it's not going to be easy with the SDG coming. So we have great results, and this is one of the few, I would say, that diseases that has excellent best practices and in order to move forward. Look at the Rollback Malaria Partnership. Look at the Stop TB Partnership. All of them going down. Now there is a new revitalizing Rollback Malaria Partnership. So what are they going to do? Political advocacy. And I think the malaria community, it is fragmented in a way, and it needs to become more joined in order to show the best practices that put people back into society, because there are risks out there. It's too competitive, and we haven't talked about non-communicable diseases, which are becoming the new kid on the block. Thank you.
Questions?
Thank you for the excellent panel. My name is Neeraj Mistry. I used to be the medical director at the Global Business Coalition on HIV, AIDS, TB, malaria, and certainly worked with ExxonMobil and other industries. I most recently headed the Global Network for Neglected Tropical Diseases. It's been an interesting sort of career path for me because I got to see the vantage from various disease issues. And you see the duplication, you see the complementarity, you see the synergies. And even as we heard all the presentations today, the malaria world has so many different interventions, but we all siloed by our day jobs. We focus on a particular approach, a particular intervention, a particular competency. So the question I have, and it's building on what Marcos is saying, is a very practical question. Who is actually looking at how to piece these puzzles together? Whose day job is it to actually find these innovative partnerships? Because we all go back to our desk and do the same thing that we do. At the Global Business Coalition, that was my day job, to broker those deals between corporations, between industries, NGOs, and governments. So if someone had an innovative idea today, where in the malaria community would they go? What would that platform be to actually foster those deals?
One more back here.
Thank you. I'm Rainier Escalada from Plow as well. I'd just like to build up on the comment from Dr. Espinal, no? And to contribute to the discussion in a sense that we do agree on the importance of best practices and success in strengthening partnerships, not just globally, but among the countries. And we have the perfect mechanism in the region of the Americas. For the 9th year this year, we're holding a search for the malaria champions of the Americas. And what we honor are countries who have actually done well and who tells us exactly how they did it. Two examples I'd like to highlight is, for example, in 2010, we have already recognized Suriname as the national program of Suriname as one which has capitalized on partnerships at the local level. One of the story behind the success of Suriname is really harnessing the power of partnership within the country. So we're learning from them versus them learning from global efforts. What we're seeing is that the figures that you saw from Dr. Espinal earlier, those figures are real, and we were out to know what the stories behind those things are, and we realized the countries know how to do it. In terms of integrated programs, we have a champion in 2014 or 2015, if not mistaken, and that was the Dominican Republic. They have demonstrated how malaria, integrated with other vector-borne diseases, could actually push elimination to where they are right now. Of course, they have not eliminated yet, but they were able to do a comprehensive integrated program that shows that elimination of a disease like malaria can be done in an integrated fashion. So what we're saying here is that we offer those examples from, right now on year 8 or 9, we have 24 stories, best practice from 12 different countries. And we encourage you to look at our website, Malaria Champion of the Americas, and you'll see those real stories. They're documented. We're partnering with the UN Foundation on this, and we have stories from 12 different countries.
Thank you. Any other questions? You can take one more. Okay, thank you. We'll go back to the panel, and we've had a couple of comments on the importance of best practices, but also on integration, both with other diseases, but even within malaria, the community itself. Who would one go to try and sort of build some of these partnerships, and the importance of, or the thought about sort of potential competition from other diseases as priorities increase. So I'll just go back to the panel, let you sort of wrap up and maybe touch on some of these questions or comments and give us a final thought.
Well, I'll step out here. I agree with the respondents and the questions that they had, because it is a very fragmented field with a lot of different players who each have their own niche, their own area of passion, shall we say. And it can be confusing for corporations like ExxonMobil to determine, where to go, who to partner with, et cetera. In some ways, I think we might be a little fortunate because we have a very vast internal medicine and occupational health department that's out there on the front lines dealing with our employees and can better inform in internal partnership with our own foundation to tell them what we're seeing, what we're experiencing. I think that there does, the better models that I've seen try to bring the various stakeholders together. And one example I can think of is our experience in Angola, where we helped convene a national forum for malaria partners. And that's where we brought together all of the different entities, each one with their own specialty area. But we had to, it was an example where we came around a table and we talked. We developed relationships and we learned how to leverage each entity's unique strength. Because I think without that, we would have been competing in some instances, working against one another or duplicating precious resources, et cetera. And I think with our surveillance of just cases treated, we were able to see cases, this was in the mid-2000s, I guess, we were able to see cases treated with coartem, go up within a number of months from 5,000 to 90,000 just by talking and leveraging our collective strength. So I do think there has to be that coordinating body that brings it all together.
Thank you. Margaret? Sure. So like Dr. Espinal suggested, I do think there's a lot of optimism now around the sort of reconstitution of the Rollback Malaria Partnership. And as that gets settled with new leadership and new board, and the partnership committees are starting to meet regularly. So I don't know the perfect answer to your question, but I do think that RBM will continue to play that central coordinating role. There's the Advocacy and Resource Mobilization Working Group and a Strategic Communications Working Group and a more technical group. So I do think that will continue to be sort of the hub. Obviously working closely in conjunction with WHO and others. On the SDG point as well, as we know in the report, the WHO, the Global Technical Strategy, and the GMAP, or the AIM, all these acronyms, but it actually mapped out where malaria intersects with it's 16 of the 17 SDGs. Of course, we know that there are true intersections with education and water and sanitation, and actually I challenged at our leadership summit, I said, but the one SDG that WHO couldn't come up with a connection was life underwater. And I asked the champions, come back to me and I'll give you a prize. And within a few hours, someone had pulled up all these research articles about how ocean temperatures are correlated with malaria incidents. I don't know if it's true or not, but like you said, it's all interconnected. And I think part of the real challenge comes down to the vertical appropriating and U.S. government funding. I think, there's some real benefits to it, and then there's significant drawbacks. And I think there's actually a lot more collaboration in country sometimes, where you do see the PMI and Global Fund and working in conjunction with PEPFAR. Some of the collaboration is happening, but I think we'd all want there to be greater collaboration across. It's just, when there's talk about investing in, when the Global Fund was talking about, right, moving towards more of a global health security model, I think people were worried that the U.S. government doesn't up. They like it very tangible, straightforward. They like, result. It's a difficult case to be made. So I think there are some real political challenges when it comes to, if we're talking about real integration, but certainly there's some things we can do in the interim before we have an evolution on partnership. So I think just to maybe echo, malaria in the Americas is an excellent example of I mean, like Appelma and others that reward countries for good behavior or showcase them and provide a forum for learning and best practices and working across areas. So, and certainly in the Americas is a great example of where you can't just work on malaria. I mean, we've talked about, you know, even though many countries are close to elimination, you talk about malaria in some of these countries and they're like, we have bigger problems. Zika, dengue, chikungunya, you know. So how do you really talk, I mean, in context like that, it really is a matter of an integrated vector control approach. Otherwise, it's just, you're not going to be able to move the needle, so.
Thank you. Sean?
You know, I think the funding sources sometimes lead you to believe that there's going to be a lot of breakages and stovepiping and all, because you've got different groups that are funding in different ways. But we've actually been finding on the ground more and more that, you know, it always helps a financial crisis, always helps everyone to look at the different efforts that are going on. I think the other thing is the fact that many of the groups, like the Global Fund would be one, but you look at the President's Malaria Initiative and others, having multiple sources of funding actually assist in that integration of the different activities, because as we work with the Global Fund or we look at the President's Malaria Initiative, they're combining it with work that we're doing with USAID as well, and so there's some consistency there. And on the ground with the implementation, particularly in more difficult countries, having a multi-sectoral platform where you're addressing health and education and agriculture all together, there's a tendency to bring those more and more together. I think the other approach is that including the local government into the solution and addressing the type of responses you're having, not as a malaria response, but a country level response. And so what are the things that we're doing in this country, and then you try to feed in together. And so we've been having more and more success on that in looking to ways that we present those type of options, and then going to donors saying, this isn't the way we do malaria in Mali, and this isn't the way that we do agriculture in Zambia, and this isn't the way we do food security in Ethiopia, but bringing all of those people together as we present our overall integrated methodology to the donors. And I think they're responding to that more and more because it shows results. It's a combination effort, and I think the stovepiping issue is there. You know, we all know there's benefits to having the different funding sources. Obviously, earmarking is not the best approach and maybe the most effective one, but it does get the resources out there, and there seems to be an effort, you know, the funding seems to come through in those ways. I think it's really beholden on us as we implement them to make sure we're combining our efforts on the ground.
Thanks, Sean. Yang?
Probably will echo what you just said. You know, malaria elimination or eradication in particular is a national affair. You know, it's a lot of us who have worked in the developing countries, sometimes it's hard to remember that because of the you know, corruptions that we see every day, and you know, human rights abuses that we heard. It really is a national affair, and the way we work needs to kind of conform based on what's happening in the social and political situation in these societies. And in our experience, you know, it's not an easy thing to do. We all, I'm sure, and everyone in this room understand the difficulties and complexity of that. But we have to, I think that we have to resist, you know, lasting back to how we are used to work and how, you know, how the way, you know, the way we work in a simple and kind of a silo way. And I think somebody in the audience mentioned something about, you know, being able to work with any type of government, you know, regardless of how we feel about them. And in my experience, in particular in Myanmar, you know, the political problems and social problems, they have been there for hundreds of years. And these problems are not going to not going to be solved the next, you know, 10 years, that, you know, when we want to eliminate or eradicate malaria, and that, you know, next 10 to 20 years that we're looking into, there has to be some sense of urgency. I hope that everyone feels that, everyone in this room feels that sense of urgency for elimination because of the resistance that we are seeing now. So that will be my message, is that it is a national affair. Then we have to be able to find all the good people, regardless of organizational affiliations and institutional affiliations, and work with everybody and pull good people out.
Great. Thank you to all our panelists, and please join me in helping thank them.
Please stay with us for just 5 more minutes. Gina Rabinovich is going to offer some words of benediction here at the end of the
Just go ahead and sit. It's all right. It's all right. Go ahead and sit. Then we don't take time. So I was asked to be rapporteur, and that's always, we've had a pretty rich afternoon from a number of different perspectives. So let me just highlight a couple of points, all of which you've heard. So I'm going to try to tell a different story. We started off with a global perspective, and whether the glass is half full or half empty, the news is mixed, and you need to recognize that. Yes, fewer deaths. Yes, fewer cases. The rate has gone down. We still have fairly big numbers, right? 212 million cases of clinical malaria means many more are asymptomatic or somewhat asymptomatic, at least not acutely febrile and seeking care. So things have improved. I'm not sure what year that gets us back to, because things got really bad in the late 80s and 90s. And we haven't gone down, I don't think, below the numbers that we reached once upon a time. The other thing, the second part of that, is that we've gotten a little bit smarter about not saying it's hopeless everywhere. There's clearly been progress in many of the countries. Elimination has been reached and certified in 7 in the past 5 or 7 years. And there's 21 countries that are aiming for significant and measurable progress, measuring 0, by 2020. So this is audacious, actually, in the context of 212 million cases. And what's happening is aligning the strategy, the funding, and critically, what the countries want to do is important and critical for elimination. How that takes us to aligning all of the countries towards eradication is something we haven't entirely answered yet. And WHO, with its Strategic Advisory Group on eradication, is wrapping its head around that. Now, there's a valid hypothesis out there, and it works. We can't forget that. For where malaria has been transmitted, like Sri Lanka, and has been certified, cleared, the tools that we have can work. And that's even in the context of recognizing, I think it was Chris, but also Bernard, there's no perfect tool. We're not depending on a single tool. It's a strategy on how these get rolled out, right? Surveillance, vector control, diagnosis and treatment, hopefully an accelerant like MDA or something else, and overall data at the point it becomes programmatically relevant. And so, and what are the reasons that it's so challenging? What are the risks that we're facing? Well, resistance, we've spoken about that. And that's both to drugs, which is more evident in one part of the world, and vector tools, particularly insecticides, in another. But it's residual transmission, which can be behavioral or what's selected for. Political disarray, we've had several very good examples of that. And lack of financing. And still trying to figure out what can we achieve in Nigeria, what can we achieve in places with an EAR of 300 or 500. But I think the key point in the face of all of that, I don't know if it was someone that said, if we can't work in Burkina, if we can't work in Angola, if we can't work in Haiti, why are we doing this? We have got to figure out how to work in partnerships, how to work in Myanmar with the military to drive this agenda forward. At the same time, there are big challenges that require innovation. And we talked about little I, we talked about big I, you're stuck with this one, Stephen. And whether it's iterative and the next step, and we need the drug that will overcome that next molecular target resistance, or it's transformative. And believe me, there is no funder on earth doesn't really want their interventions to be transformative. Everyone would like that. And yet, how is progress being made? By that next tool that identifies and addresses the gap that's left behind, and that gets tested, and then it improves it. And then, so there is plenty of space for both. And to reflect back that all of the tools we're using today are new, and it's likely that we will not recognize what that malaria package looks like a decade from now. Now, there are things that were spoken about during the day on how things can work better. And I was able to pull them out even though the panelists didn't quite answer them. Lee spoke about closing that loop so that the research that gets undertaken and prioritized targets a problem that's faced in the field, which means people in the field need to be talking to researchers within their communities or across communities. Steve talked about compelling case for integrating what's usually called, research strengthening capacity, whatever, but integrating training and country leadership development into the programs that are in, whether they're delivery or R&D. Patrick spoke about leveraging the data that's being collected in northern countries because they become a reflection not only of epidemiology, but particularly if it's done across countries, potentially of resistance patterns. And Larry reminded us to focus on the mosquitoes. He thought about his program with vaccines and MASEP, et cetera, but have we focused enough on the mosquito? There are several areas of creative tension which are unresolved. And I can see both sides of the coin. On one hand, both this panel and others spoke about the need for integration. And we would love to have it all happen in harmony and be planned. And for any of us that have tried to tackle and convince the malaria community to fund bed nets and the data on lymphatic filariasis as a driver, you can't find, once you do the trial, and then no one wants to cross that because they want accountabilities in their own disease. It's actually quite frustrating. But at the same time, I am not sure, and this is where I'm a little not sure how we proceed, that polio would be where it is now, for better or for worse, if it had to be integrated. Would we have been able to achieve what has actually been done in Nigeria and India if it didn't have a program that was driven, that was accountable, that was being beaten on every day in terms of what they had achieved? Not sure. And it may be that that's not where we are with 212 million cases. Maybe that's something that happens at a later stage. The question of strategy is one in which we're being told, and that's what the WHO press release today says, hold the course, sustain the gains. Bernard said malaria responds, but he also said malaria returns. And that's the data that comes out of that analysis across countries of if you eliminate, it's actually fairly stable. But if you get it to really low levels like Sri Lanka and then walk away, which many countries are poised to do at this time, it's a certain recipe for disaster and for epidemics. And that places malaria as this phrase that I think resonates to me as the parakeet in the global health mind. It tells us when things are falling apart. And it tells us within one season, at most two, because that's when the epidemics return. So as we watch financing ebb and flow, we will see the results of what it is that we're doing. The last comment was on partnerships. And what impressed me about this panel was that whereas 10 years ago we were talking about public-private partnerships and negotiating the deal and talking in the same language, the concept of partnerships and what needs to be achieved by many of these groups has actually matured. And I was there at the birth of Nothing But Nets and a lot of excitement, and I was going, it's really, the right metric is not really $10 and save a life. It doesn't cost as much, but you need a lot more. This is really complicated, but it worked, right? But what I heard was the messages have evolved, and the program has evolved, and now facing the realities, you're going beyond the vertical, beyond the bed net, and thinking more because you're already feet in the ground, you're facing problems. CRF is a large organization working in many countries, But you, as well as other FBOs, you're not there for a project. You're there for the long term. It makes you an ideal partner to figure out how to leverage that commitment you have to the long term. And Exxon talked about health impact of its interventions, which are measurable not only on the workforce, but in the communities in which you are. And it really talks to the role of the private sector in healthcare delivery, which in one company at one site is great, but if you think about leveraging what companies should be doing across the perspective, it really becomes value added to the community. The last question, which Jim looked at me and just smiled, was the question of whose day job is it to build coalitions? Because this is a governance question, and it's something that one World Malaria Day, RBM put out this wonderful half-page ad with all of these heads of malaria leaders. And I have used that and said, who runs malaria? And that's the reason we have a partnership structure. You have a global technical strategy, you have people worried about financing, you have private sector, public sector, FBOs. It's actually either a mess or it's a very rich network. And I prefer to think of it as a very rich network in which, who runs malaria? I'm sorry guys, we all do. I don't think we'll ever have, I don't think we'll have at this point one group that's responsible for building it all together. Maybe at the end, as Steve talked about, we need a headquarters-driven model, and we will morph to that to actually bring it down to its national conclusion. But right now, elimination is a national decision, and what we probably need to build are better tools to handle the negotiations and the data sharing, et cetera, across the borders, where it can be a very painful exercise if there's disalignment of goals and strategies around borders. So I think this was a very, I hope that's what you heard. That's what I learned today. So thank you very much. And I was very excited about the nature of the discussions today. And the eradication goal is not going to go away. So we will continue this to be seen. Thank you.